can see my screen or not. Great. Okay. That's excellent. Hello, everyone. Let me tell about myself. My name is Dr. Shahriar. I've been a AMC tutor for last 8 years. Uh, I think via social media or from friends, some of you might be knowing me. I've been taking MC classes, like it's been a lot years, So if I count my own preparation, then, it's like a almost 9 years journey or 10 years journey. But in generally, I've been following all these things and trying to be very update with the MC things actually. All right. I mean, I'd recommend you guys to use a laptop device for the classes would be more appreciated. Yeah. And if you see, for MC, like I just highlighted the first slide in that way so that, it's looking little eye-catchy that in order to pass the MC exam, these are your mandatory things actually. Okay, so first of all, starting with a theory, like which we will teach, or even if someone is attending, if they are, yeah, not going to attend, the important thing would be in this case actually that the theory, the recall, these are the mandatory thing. Theory again would be covering from John Murtagh. Other than that, we have our own SMA notes. Actually, you can also follow them. We'll also give you some demonstration on that one, how the notes and everything looks like actually, right? So mainly, definitely it is very important to follow the John Murtagh. Alone studying John Murtagh is pretty difficult actually. So that's why classes are important. Exactly what points to study, I'll try to highlight for you. Okay, and that is one of the reasons you should have a John Murtagh 8th edition. Now I'll start asking a quick question. Do you have John Murtagh 8th edition in your hand now, actually? Do you have John Murtagh 8th edition with you? Yes, so that's the thing. All right. Okay, if not, like try collect. That would be a mandatory thing to attend our classes. Don't worry. I mean, after the first class, we'll have a 1 week of gap. You can also attend the second trial class as well, no problem. But in that 1 week of period, we'll be finishing the maximum admission, and you should try collecting the John Murtagh actually. So having John Murtagh in your hand and not having, you will see some differences actually. I would recommend to have like John Murtagh 8th edition because it is the latest. From John Murtagh 7th to 8th edition, there's another commonly asked question, Doctor, I have 7th edition, 6th edition, can I continue? See, the treatment guideline has changed 10 to 15% in every edition. So example, um, some of the cases like atypical pneumonia, previously we used to see there were mentioned doxycycline. Now, according to the new books, I found that there was azithromycin was mentioned. So when the question would be there, so you have to pick up the right one. Even in the UTI cases, we have seen 1-2 changes. In MI cases, there are some management changes. I mean, that's not a question, 9th edition. I mean, when it will come, we'll see that actually. No updates I haven't found yet actually. Every 5 yearly, they're 5-6 year, they change one edition actually. Okay, so at this point, I think we don't have to worry about the 9th edition. Okay, when buying the John Murtagh, also be watchful buying the John Murtagh 8th edition general practice because there is another version smaller. It is called John Murtagh Patient Education. That will be needed for someday for AMC Part 2 or when you will be working. So please buy the John Murtagh 8th edition general practice, the bigger one actually. Some places it is sold in 3 pieces actually, because originally it is a 1 book, similar like Davidson, actually the size. But it is in some countries because when they print it out, it becomes more bigger. So in some countries, it's divided into 3 pieces actually. Okay, so some people say, John Murtagh isn't it 3 books? No, it's a 1 book, but some places it is sold in 3 volume or 3 pages actually. Okay, so that's the thing. So we'll be guiding you. You have a respiratory system coming up today, and these are the particular things you need to focus on actually, like theory. And I mean, every Sunday, I mean, guys, every Sunday we have major classes in Sunday and Thursday. Friday, we will upload a something called overview, like what to study for the respiratory system. Okay, so it will be kind of like that, what to study for the respiratory system. Today in the beginning of the class, I will tell you that one. In future on the Friday, I know we'll post that one. We call it actually overview. It's not a live class actually. So our main classes are 3 hours. It is Sunday and the Thursday, 7:30 p.m. Sydney, 3:30 p.m. Bangladesh, 3 p.m. India, and 2:30 p.m. Pakistan time. You can adjust your um, time frame and that thing actually, right? So that's one of the thing. Okay. Next coming thing, other than there's a question bank, any question bank you can follow. Once the course started, we'll also post a question bank actually. So don't worry about that one. You don't have to buy separately question bank things actually. We'll be uploading few question banks. So don't worry about that one actually. If you want to invest something, invest on your study hours. Okay, remember this word. If you want to invest on something, invest on your study hour, invest on your technique, invest on a study partner actually. Okay, so it's very, very mandatory. Someday you'll understand what I'm saying actually. Another thing, we have a group. Did you guys know, or are you guys added to that particular group, Shahriar's AMC guideline group? That's the biggest forum for AMC discussion. There's a lot of free questions being posted all the time. A lot of people, you see, they are commenting 30 comment, 40 comment, 50 comment. Some comment reach like a 100. Okay, so that's how the things are actually. So um, are you guys added? Or if not, you can just search with Shahriar's AMC guideline. You will find that group very easily. Make sure your Facebook is a genuine one. New. If it is a new one, we may not accept your request in that one. Our moderators will not accept your request in that case. Actually, for the privacy of the group, in that case, you can inbox your identity as a national ID card. That. Then we can help you getting through that actually. Okay, so that's the thing. Yeah, like why new account? I mean, Facebook has established on 2008, and why a new account actually? That's the question actually. Okay, so we are a bit aware of the fake accounts actually. We're not saying your account is fake, but you need to prove the identity. So in that case, if not added, um, it will be better. You can send us your identity to add you back actually. Okay, is it clear about the groups? So study group, guideline group, it's a fantastic group. Like, keep uploading question. You can also repost the previous questions actually and try to participate on that one. In the recall classes, I'll teach you the basic, standard, classic, and new recalls, but you should also participate in the study group and the forum. Some people also make WhatsApp group, Telegram group, but make sure in the early stage of your study, it's not so helpful actually. Okay, but rather, if you have a 3-4 people study group, that's very helpful. But if you make a 50 people WhatsApp group, I mean, only 1 or 2 is getting help. Those will be active, and actively can answer actually. Some people will practice on you actually. If you be like in silent observer, nothing will happen with you. Okay, and finally, a good course. I mean, I believe, like, because 1,300 plus, I think 1,310, I think that's the number. You can trust us actually as a good course actually. Our website is this one. Okay, and I'll be trying to be a good captain of your ship, not as a like a Titanic captain, but I'll try to take you to the port actually. But all the studies you have to do will guide you to the best possible way actually. All right. Moving forward, about me, I've been founded this thing. This is the number you can use. Like, if you don't have my number, like, please collect this one. Yeah, so this is the thing. If anyone is new, you can collect this number actually, or you'll find this number in our website. You can WhatsApp actually in this number actually. All right. And usually I try to talk on Friday basis. Actually, not every day is very difficult, you can understand. All right. So I also train a lot of students. I've also trained a lot of teachers as well at the same time. All right. So yeah, so AMC is my main course, which I cleared, and but other than that, actually, I teach PLAB, and actually USML is in some progress. We haven't thought about it yet, actually, in that way. All right. So mainly it's the AMC thing, what I do actually. So next is the similar thing, like a course related. We have already um, theory, recall, group discussion, question bank, and computerized mock actually. Also, this is important actually. Okay, computerized mocks actually. So we have a lot of mocks every week. So some of them are manual mocks, smaller mocks. We'll be uploading file, and you will take those mocks. And in the middle of the course and end of the courses, we'll be also having computerized mocks actually. Okay, by the time you will be finishing with us, um, there will be 25 smaller mocks, and there would be at least 2 large computerized mock. Is it clear, everyone? Like, make sure you at least attend 2 computerized mock with us. I mean, we don't charge for that. At least you attend to computerized mock with us before going to the final. Is it clear, everyone? Because a lot of doctor messed up with time management. Okay, I've seen a good student, everything good, messed up with time management. Okay, because when you are taking smaller mocks with us, uh, you can take it. But everything happens when it's the large scale game. So for large scale game, you need large scale practice. Please comment, leave a comment in the comment section. Am I loud and clear actually about these things? So theory, recall, group discussions, forum discussions, question banks, and regularly taking mock with proper preparation. I can guarantee you that you will almost pass actually, like for sure actually. MC exam is getting difficult actually. Till date we have the 90% of the more success rate. Sometimes month wise few things may vary actually, which we will tell you in coming days. We will close the batch actually. Okay, yeah, for scratch we'll be starting from the John Murtak actually. All right, I'd like to welcome you again. Those of I think maximum people joined. Welcome to Chess Medical Academy. We'll try showing you a lot of animated thing, drawing thing throughout the course actually. So don't worry. I offer you MC MCQ course and MC clinical course actually. Right. From this current batches, there will be also some offer available. Like when you join, you can actually join for both at the same time. Okay. So that means for the clinical, in that case, we will give you some offer price actually, in advance if you join for the board course. So that means till your MC journey, you will be with us, So that's another excellent thing actually. So this is the thing. So this is the current number. It's a big number, right? What do you think, guys? It's a big number, has passed over the last 8 years actually. All right. Yeah, we post the recordings. Today's class, I'll be posting tomorrow. Is it clear, everyone? Some people may have also this confusion. Today's class will be posting tomorrow actually. I'll be coming to the book section, my dear, don't worry at all. Okay, and those of you who have also taken admission will be also updating you about the book links actually, so they'll be downloadable. 17-18 book links will give you at the same time. Don't worry, give us some time, we'll get you through everything actually. All right, and 600 I know started working in Australia, so try to be in touch with us. Sometimes we try helping networking by also, if you after passing MC, if you can ask us like, doctor, do you know anyone? I'm trying to apply in this state. Any doctor, if in your concern, is working in this hospital. Every hospital in Australia, I have a doctor, who are previously my student actually. All right, so that's the thing. And yes, this must be a interesting question, right? Have you thought about that? Why you are choosing Australia? Let's see your opinion. Let's see your opinion. Why you are choosing Australia? Let's see your opinion. Then I'll tell, like, my version actually. All right. Any guesses, like, why you were choosing, guys? Please hurry up, guys. We don't have much time. A good one. I mean, I appreciate that one. Someone said money, actually. Very honest person, say, actually, finance better. Someone said in a subtle way, finance, actually, rather than saying money. But I like the person who said in the beginning money, actually, loud and clear. He knows what he's doing, actually. Okay. No, see, I mean, if you just tell better salary than Asian country, I think it's UK, US is also, and many Qatar, many having also. That's the thing actually. All right. So many thing, I think what we started, some cases, what I have seen, many does not feel that secure anymore. Financial stability, good quality of life, many of those things. Let's see, what I have for you in the presentation actually. Okay, wife working in Australia. Oh, wow. I mean, so super fast for you. Okay, my dear. Lucky you. Okay, now I also put that one actually. Okay, so that's a very basic initial salary when you just started. Even after finishing the GC, this all thing means after 1 year, this price will be up. All right. So after 1 year means initially we call it when you get a job and then join, you get a provisional registration. After 1 year, it's called the general registration. General registration. So after general registration, you can do locum. Guys, do you know what is locum is actually? Sorry about this, the thing. Do you know what is locum? Yes, that means in our country, we call it cap. I mean, those of you from Bangladesh, you must be knowing what I'm saying. A local word we means cap. Now, it means I like uh, you work already in a hospital, but sometimes you also go outside part time, like in our country actually. So in Bengali we call it cap. They call it locum. I mean standard word. So what do you call in your country actually? So let me know in the comment section. It's good. When you do locum, I mean, I was talking to my friend. He was doing a locum. So he mentioned he got like 1,000. He got like nearly 1,000 um, 200. Okay, so it's like a $1,200. Okay, per day. Is it clear, everyone? Like it's separately. I mean, some other hospital will call you. I mean, today we need a shift. Can you join? And you can go and join. So that would be like a, yeah, for one day you can join and you will get like a, you know, 1,200 actually. Now that's like a salary of your whole month in the country. If it might sound little harsh, but it is true actually. Okay, so especially everyone is looking for the locum things actually. Every month, some people try to do 3 or 4 locum in any way. So you can understand every locum you're getting 1,200, I mean 1,200. Yeah. So your quality of life will get better and better. As the time progresses, your increments would be higher. It will no longer remain 8,000. It will be higher. So from initially starting with the JMO jobs, we call it junior medical officer job, then senior medical officer job. Okay. So after that, you can be register or senior register, and in future you can be a consultant actually. Some other day we'll talk about what are the consultant pathways and this that, and also how to become a GP. We'll also talk about that one, and how to become super GP. That is called the FRS-CGP. Okay, so as a doctor, then you wanted to be a consultant, you have to go through the RSCGP fellowship. If you want to be GP specialist, someday you have to go through the FRA-CGP. I'm just trying to type the word so that you can Google it later. FRA-CGP is like a GP specialist. Okay, I'm just trying to type this one. Yeah, have a look. Yeah, I'll talk about those later. Let me finish my session first, actually. Okay. Next is a like RACGP fellowship programs. Okay, that's for the general actually. And initially, when you join, that is something we called. You try to get a job offer in Australia after MC1 or after MC2. Some people ask me also this question, can I get a job after MC1? It's very much actually. Those doctors doing job 600, out of them 400 got job after MC part 1 actually. All right. So this is the thing actually. So job offer, then there is a provisional registration. Guys, please listen carefully. I mean, I'm not able to chat now. So job offer, then provisional registration, then you get a general registration. I'm just chatting in the chat box right now. So job offer, provisional registration, then you get the general registration. Then you are ready for whatever the things you want. Now, if you want to go to GP route, that's open for you. If you want to be a medical officer, that's also fine for you. But if you want to go to WBA program, some other time, I will talk about that one. I'm just giving you superficial idea now. Is it clear? So GP route, hospital route, WBA route. GP route, hospital route as a medical officer, WBA. WBA is also medical officer, but we'll talk about that program some other day actually. All right, that's the thing. Great. We'll talk about in coming days about the training programs as well. Okay. Our question was why Australia? Very good salary. That's one of the very tempting. Um, best livable cities. So even I could do in 2021 index, even I think 23 index, and so some of the best livable cities. So you'll feel that. I mean, when you're there, they're really great. I've been in many countries. I've been in like 30 countries in my life. Australia is one of the finest actually. Um, Europe, I find also very nice, European country, but there's a language problem, right? European countries are also very nice. Yeah. So that's the thing. Specialist pathway, I have a video about the specialist pathway. Please go check that one. And today we're not going to talk about the specialist pathway actually. Or you can inbox me someday. I mean, we can, if I have time, I'll talk about you actually. Every specialist, they can also try the specialist pathway, but chances of failing is over 95%. Understand that? And that verification required over 10,000 Australian dollar for a specialist or consultants actually. All right, so that's another thing. Another interesting thing, no need of English test for appearing in the exam. Okay, now you guys are coming in. Quick question, can you appear for MC exam immediately? Just for example, can you appear in MC part 1 exam immediately? That's my quick question. If you have done the verification, you can actually, you can actually, yeah, you don't need English test for MC part 1. If you have the if you have made the account, you can appear in MC exam immediately. There's no problem with English test. There's no problem in getting a dates, which we often see and suffer with the PLAB candidates. Actually, PLAB candidate, they don't know even in 1 year they're going to get a seat because their English test is not clear. Actually, another thing in this case in Australia, there is an option for PT. Have you heard about this term PTE exam, guys? PTE exam. Anyone? PT exam. Now, PT is much easier than IELTS and OAT. OAT has recently been very difficult, actually. Over the years, the listening part has become more difficult. So, PT, you can give it. Yeah, congratulations, someone cleared OAT. That's good. All right. After passing, no, actually, while you apply for the job, say after MC part 1, let me come to the video. It looks like it. After MC part 1, if you want to appear in MC2, you don't need English test. Is it clear, everyone? Okay. After MC part 1, if you want to MC part 2, you don't need English test actually. So for exam, you don't need English test. When you need English test, when you are applying for the job. Okay. When you are applying for the job. So if you are applying job after MC part 1, you need English test. If you're applying for the job after MC part 2, you need English test that time. So only that time. Okay. That's the thing. I hope that's clear to all of you. So summary here, you can start preparing and you should start studying rather than thinking too much. There's another group I wanted to say, they keep thinking too much. Oh, when I'll start MC, I'll start PLAB. Many I saw messages. They texted me like a 1 year back. Again, they texted, Doctor, I'm thinking of starting MC. Can I attend the trial? I said, okay. Yeah. But almost like a year back, the person, I mean, no offense actually. So don't think too much. Start something actually, start your career actually. Any country you can get settled. Okay. Let me assure you one thing. Any country, if you want, you can get settled. Yeah. But you just need a hard work and dedication. Even if you want USMLE, you can also get settled. But technically, it is said that about USMLE, if you're not a fresh graduate, it will be more difficult for you actually. Is it clear? If you're not a fresh graduate, it will be difficult actually. All right. About the time frame of the job, it's not guaranteed. If your CV experience, these papers are ready, and if your interview went good, I saw the lowest in 1 month someone getting job. I also saw someone with a 1.5 year, 2 year to wait for the job. Is it clear, everyone? So on an average, if I compile, so nearly like a 6 months to 8 months. I mean, all the candidates like those are doing job. I would say like that's the thing actually. Yeah, all right, great. Sorry, guys, I'm not following all the messages. It's too many actually. So again, that's a compilation. High salary, best livable cities, beaches. Like some of the best beaches are there, other than the USA, Miami, and some things like Bondi Beach. I mean, it will be unforgettable memory for you actually if you go. Like it looks like a movie set. Some of the beaches, and anywhere you drive in 15 minutes there is a beach. You know. So that's very interesting actually. So getting faster date for MC part 1 is a very good thing. So that you can start preparing. All you need a good preparation actually. So no English is required. You can secure a job even after MC1 if you have a 2 to 3 years of experience. Now here is a thing, highly recommended to have 2 to 3 years of experience actually. All right. All right. Another question sometimes came to me, doctor. I mean, I'm living in Australia. I'm planning to attend your course, but I have some clinical gaps actually. Will your company or academy has the ability to provide CPD? I mean, are you familiar with the word CPD, guys? Actually, just asking you as a yes or no, actually. Please comment in the comment section. Are you familiar with the word the CPD? Now, if you're not familiar, let me tell you, CPD will be mandatory thing when you will be applying for the job. Okay, if you have already continuous experience, you don't need anything. But if you don't have a continuous job experience, in that case, you have to fill up those areas or showing some recency or showing some certificate as a CPD points. Clear? Some CPDs are free in Australia. Some CPD paid CPDs available as well. And also this CPD is also like, any courses also can offer any registered, like our course is a registered course, Australian Medical Council accept our certificate, which is a great news. So you will get a 5 months of a clinical gap reduction, summary thing. If you go to YouTube and search with one video clinical gap and type my name Shahriar Ahmed, you will find a nice video on the clinical gap. So if anyone here is having a clinical gap, like a, so 1 year gap is not a big thing, but if you have a 2 year or 2 year plus gap, you need to think about like what to do in that case in future, because with a 2 year gap they will not give you a job actually. Okay, so please watch that video. AMC clinic, if anyone is a class monitor attending, if possible, please share that video link, I think, with the people here actually. Okay, appreciate it. I mean, someone can copy from the YouTube and share it, be really nice. So there's a AMC clinical gap, and if you type my name Sherman, you will find that video. If you have a clinical gap, it can be something actually. Yeah, okay. One quick question. Home country, is it counted as an experience? Yeah. Yeah, 5 months you'll get actually. So home country, is it counted as experience? Definitely yes, actually. So where you will get the experiences? Then the 2 3 year experiences I'm talking about, which experiences are those? Those experiences are your home country experiences actually. Okay. Yeah, home country is fine. Home country, government hospital, private job. Okay, government hospital, private job, anywhere it's fine. You just make sure that particular hospital has some website, that clinic has some website. Some cases, just my suggestion. And the supervisor you are choosing, make sure that person is responsive over the email. That's the only thing actually. Okay, thank you guys for sharing that quickly. Okay, internship not considered as an experience. Okay, internship, that's why you are joining as a, what is your level of joining? Okay, that's a good question. What is your level of joining in Australia? Okay, your position is a RMO, junior medical officer, resident medical officer, senior medical officer. But what level you are joining? You are joining HMO level 2. I'm typing that one. I'm typing that one for you. HMO level 2. Okay, that's the position you're in, because you have done the internship. That's why HMO level 2 and HMO level 1 positions are not available, because those more confined to the, yeah. Guys, your personal question would be very difficult to answer in the session, but I'll try to answer those things in future. In a lot of classes would be there regarding in clinical gaps. So don't worry about that one. We'll cover that one. So summary here will give you a certificate that will cover your 5 months for MC part 1, another 5 months for MC part 2 if you join actually. Okay, so that roughly uh, you can get a good coverage actually. Okay, nearly a year coverage actually. Why not 6 months? Because 6 months is a diploma certificate. So diploma they will not count actually. Otherwise, we wish we could give you 6 months of coverage actually. All right. Now here is the thing. Yeah, that's how when you complete the courses, the certification and things, may come up actually. All right. So far, particularly, you know, we have been trying our best. Yes, we have come across some of the best academy over the years, actually. Many, because of the passing rate, probably. I mean, many, you must be heard saying that, they have the best passing rate, actually. Teaching wise, I mean, many can be good. The passing rate wise, I think we are far more ahead, actually. All right. Now, we also introduced the AMC notes over, I think last, it's 1.5 year. We introduced our AMC notes actually. Those of you registered, I think we already also send the note. This is how the notes looks like actually, like a colorful notes, main key points are given. This is how the things looks like. Some of you registered just recently, maybe yesterday those joined, we couldn't send them, but we'll send them today actually. All right, so that's the thing. So this is how sarcoidosis note looks like. So even though I'll teach from the John Murtagh, but I would recommend you to go to the notes and see the coincide things. Isn't it, is this things in 1 page and 2 page looks good or not actually? What do you think, guys? Is this thing in 1 page, do you think looks easy or looks difficult actually? What do you think, guys, actually? And sometimes I take feedback actually, so see, and when I will teach you this sarcoidosis today, you will understand that why these things are important actually. I also try to put the most important things actually. Okay, picture always helps. Like wherever you go, picture, mnemonic, group discussion with the study partner, this always helps actually. Okay, so notes should be more like colorful. We don't charge separately anything for the notes actually. All right. It is only confined to our MC student. We don't give the note subscription in that way because we have too many candidates actually. So separately giving notes subscription is difficult actually. Like we can open it as a question bank and this, that we never did that actually. All right. Yeah, colored things, that's why the color, this is another, one of the surgical slide actually. This is how, you will find in our many slides actually. All right. So this is how the things are going actually. Okay, this is a long question actually. Someone asked me a question. Maybe many could be also like that. Is it possible to secure an internship position? See, I have seen in my 8 years of MC teaching, or maybe 9, 10 years I'm following this MC, I have seen only 4 or 5. So if you ask me, is it possible? It is possible, but at the same time, I would say nearly impossible. Okay, I hope you get my answer. So if you want to do internship in Australia, in one word, is it possible? Yes, it is possible, but at the same time, it is nearly impossible actually. Okay, so that's the thing. Yes. All right. So here we go. I think so. Are we clear with the some guesses and the ideas? Some guesses and the ideas. I hope so. That's great actually. All right. Let me take you to somewhere uh, just to show you something. Yeah, it must be also question like why to choose like your academy actually. Some cases actually sometimes it's okay to market yourself. I don't find this thing comfortable, but some people don't know about us. First of all, it's like 8 years of teaching experience. I'm an award-winning teacher. My world kind of ranking is 13 if you check. Yeah, so so got a lot of awards in past actually. So then I started this MC things after clearing. Then we are very much updated. What I would say, I there's a video channel we have. Okay, there's a separate video channel. Those will be joining. I mean, probably many we have sent link to join. In that video channel, I keep updating every week, 2, 3 new posts, new topics, something always ongoing. So we also have a contro album. We'll talk about those things in future, like which are the controversial, because the controversial thing they keep giving in MC all the time. So we separately have an album and keep updating it actually. All right. We have a special students community even actually over nearly 4K of like, yeah. So they also some cases we try to get them connected in future actually. So that's also nice actually. So you will get a students community because we'll be using Facebook a lot. So it's easy to um, get in touch with the community of like MC community actually. And also I'll introduce you some of the other good communities. I mean, where you can directly get help actually. Right. So there'll be a lot of album in the video channel. So we'll talk about that one in future actually. Um, our academy has our unique, some people maybe after passing, you might be seeing mentioning them SMA notes. So that's a unique thing. I'll try to be extremely punctual always in the classes, and I also expect you to be the same to coming to the live classes, and a lot of lifetime experiences you will get actually. All right. So I'll give you the overall guidance like how to settle down in Australia. Of course, because being the most experienced tutor, I can tell you probably the best ideas like, of different doctors' stories, like, how they have settled down in Australia in different way actually. So there will be a lot of job related guideline. Okay, throughout the courses, we'll try to give you a lot of job related guidelines. And last but not the least, like definitely, I covered things from the John Murtagh 8th edition and by marking actually, which is another very unique thing, which you may not have seen in many, because it's difficult to mark on the books actually. So we'll have the notes but we'll be also marking the John Murtagh. So you should also have the John Murtagh and marking along with me. Your book will be also ready. We'll be also giving you classes on the recalls, and also there'll be a file provided. You can download that recall file. About SMA note, those are not downloadable, but the recall files are downloadable. Every classes will be happening. After classes, we'll be giving you a recall file. You can download that. You can also print it out actually. Okay, these are the things. Okay, we'll also provide you question banks, so no need to separately buy any question banks. Okay, so these are few things about joining SMA. If you have any other further questions, please let us know. Job related things in future will be guiding. I'm not taking those questions right now because we have to enter into the class actually. Okay, so let's get into respiratory. uh, let me give you, because I didn't upload the overview, so let me guide you first regarding the respiratory thing actually. Let me guide you first regarding the respiratory thing actually first actually before we start. All right. Okay, just a second. Okay, so those are a few things about the MC. Some questions I try to answer, some would be difficult. We can have a later seminar or session, definitely. Okay, now coming to this one, we'll be covering to the respiratory theory, and we'll be covering from the John Murtagh. Okay, that's the thing. Great. Now, what are we going to do? I mean, all right, so far Thursday, Friday classes, Friday's overview, mock Sunday after the class actually. So far we trying to carry this one, so 90 to 93% passing rate, but some month wise it varies, but we'll tell about in some cases. Some of the instruction: open your John Murtagh. Guys, do you have your John Murtagh with you? I recommend you to open that one. Please open up your John Murtagh actually. Yeah, class record will be posting after the class. Okay, don't worry. Yeah, if you haven't received the note, we'll be sending you after the session. Don't worry. Okay. Please open the John Murtagh. Follow the instruction initially. Follow the instruction. I recommend all of you to buy the hard copy. We're not talking about soft copy. I recommend highly, highly to open the hard copy during the classes. Is it loud and clear, guys? You have to follow the instructions actually. You know, it's very important you're following the instruction. Okay. So opening John Murtagh actually. Page number I'll tell you shortly. Don't worry. I'll tell you shortly. I mean, if you have your John Murtagh, I mean, just have it with your hand actually. Make sure you are using a laptop device and headphone for the best possible experiences. Interact by Zoom chat box. Yeah, throughout the classes, you can interact by Zoom chat. During search, we Sunday, usually we have the theory classes. Today is a Wednesday. We are taking it because it's a trial. Like 15th, we have given it long back. That's the thing. And there's a 1 week of admission. Then we'll start again. So use laptop attend live. So class instruction how to. You already got it today. Open the John Murtagh. Keep participating via Zoom. Okay, class links are usually provided 1 hour prior to the class. Some people also ask, Doctor, how would you get the class link? The link you will get through the current MC batch 57 group, and you'll get the Zoom link 1 hour prior to the class. Great. And class recording 24 hour after the class. Okay, class recording 24 hour after the class. uh, Fifth edition, sixth edition, seventh edition, none are okay. Only eighth edition is real. Okay. Then Thursday class, use laptop attend live, watch the class instruction how to follow the class on the recall. We'll give you a file, don't worry, and keep participating via Zoom. We'll tell you, especially when today is not a recall class, today is a theory class actually. Mock after Sunday, live classes every week. Okay. Um, Books, recalls, key points, and this, that. Okay, now coming to the part, actually, John Murtagh part. Uh, Try to stay with us. By the end of the session, I'll talk about some more books actually. Okay. All right. So initially we're talking about the John Murtagh and SMA notes. That's the two mandatory thing, right? So books, recalls, and key points. Now, talking about the page numbers actually in John Murtagh, what are the pages? Someone has asked, Doctor, what page actually? So I would recommend initially let's start with the asthma. Okay. Class time is a same like today, 7:30 p.m. Sydney, already mentioned. 3:30 p.m. Bangladesh, 3 p.m. India, 2:30 p.m. Pakistan. That's the standard. You will always find me, inshallah, during the class time actually. Yeah. All right. Okay, guys, I mean, you can stop messaging too much because I'm not following the Zoom right now. Let's focus on the class. Asthma, I mean, please open up the 868 page actually. I would highly recommend actually. Okay, side by side, sometime I'll open my notes. That's also okay. but open the John Murtagh will be better actually. And these are some of the others. So we'll be covering asthma, COPD, bronchiectasis, lung cancer. Okay. Also, we'll be covering the mesothelioma, sarcoidosis, pneumonia, latent tuberculosis. Okay. These are some of the handbook related things. As you can see, these are some of the handbook relevant thing. As you can see, like these MCQ numbers in handbook, respiratory is not given in a one single particular area. So we have also covered the respiratory handbook MCQ numbers for you actually. Okay. So this one will repost actually. I mean, we'll post a handbook page numbers again separately in the group. You can follow that one or can um, take a picture of this page actually. All right. So are you ready, guys? Are you ready to start? Okay. Okay. So this is like a May 2024. We're taking this session. All right. Okay. Let me take you to the John Murtagh now. Okay. Before getting to the John Murtagh, one more thing. Those of you who haven't seen our routine yet, here is the routine. It is already posted in the group. Okay. Those of you who haven't seen the routine. So we are starting with the medicine, followed by there would be pediatrics, then be surgery, general surgery, systemic surgery, emergencies. It's a fantastic routine. Gynae ops, there's a lot of gynae, and then ops, psychiatry, ethics, and some miscellaneous actually. All right. So this is how the things are actually. All right. And as per discussion, this is where we are actually. Okay. Is it loud and clear, everyone? And course, we are running from 15th of May up to 15th of October. Now, if you ask me when is the right time to take an exam date for this batch, it would be November or February, March actually. Okay. November or February, March actually. Clear, everyone? Is it loud and clear so far actually? Recall means question solving, past paper solving. Okay, today is a theory class. Okay. Dermatology you'll find in the as a miscellaneous topic later. Okay, don't worry about that one. All right, so here we go. In October, it would be difficult, doctor. You can't do it in October, actually. You will fail, high chances. Okay, let's get started without any further because people will keep having question. It's normal. All right, so I'm opening my John Murtagh. Did you remember the page I mentioned? Yeah, it's asthma, right? Guys, if you for a second, you can just open John Murtagh and we'll take questions again later on the breaks. All right. So here we go. Is the asthma thing. For a moment, I'm not following the Zoom chat box. Let's go and discuss first, actually. Okay. I'll try to help you through drawing and many other things. Okay. So opening the asthma things. Okay. Very important, like see few of the things I've highlighted. Risk factor comes often management, exercise-induced asthma, step up in the management, SGT, fluticasone, and COPD. So these are some of the important topics actually. Now, coming to the thing, like, let's start with the board here, talking about asthma. Okay, talking about asthma. Now, first of all, like what type of disease is asthma? Actually, I'm not trying to go into very much basic, but one, two diseases are very important to know. Uh, this one, please tell in the comment section, are this obstructive lung disease? Are this restrictive lung disease? Okay, that's the first question to start with. Is that an obstructive lung disease or is that a restrictive lung disease to start with? So this is an obstructive lung disease. First of all, if I add that one, this is an obstructive lung disease, right? Everyone would be agreed? Okay, obstructive lung disease. Okay, let's try to find few words for asthma. Then we'll come back to this topic, like why they are obstructive, it is called actually. Now, is it a common. Yeah, it is a common. Can you say it's a chronic? Yeah, it is chronic. Can I say it is inflammatory? If you know more words, you can add that one. We can say inflammatory. Can we say is it a reversible or irreversible? It's a reversible condition actually. So common chronic inflammatory reversible lung condition actually, right? So these are common chronic inflammatory reversible lung condition. Now associated with some of the symptoms. Now, what are the symptoms you are expecting? Okay, I think most of you must be knowing there are at least 4 symptoms you should tell. Now, starting with breathlessness, right? Breathlessness, then chest tightness, chest tightness. What else? These are the 2 major things: breathlessness, chest tightness. Can we add also wheezing? Wheezing. Can you also add cough? Now, you see, cough I'm putting at the end actually. All right, cough I'm putting at the end actually. So now here is a thing to discuss. In which case do you think cough comes as a preliminary problem? In this case, breathlessness, chest tightness, wheezing, cough. So cough being the later problem. Um, in which cases, like, another respiratory condition I'm talking about another respiratory condition. In that case, cough becomes the primary problem. So versus COPD. Yeah, there is a cough variant asthma. That's a different thing. I'm not getting there. I'm talking about another respiratory condition. So the another respiratory condition, the COPD, because there is a hypertrophy of the gland. So when they sleep at night, tons of cough has been produced, isn't it? In COPD, tons of cough has been produced overnight. So you will find COPD patient, just when they get up, they try to clear their lungs actually, isn't it? So most cases, the bronchitis, yeah, the bronchitis. COPD means under that chronic bronchitis and emphysema. Mostly we're talking about the bronchitis. Okay, we'll also see the differences between asthma and also the COPD. Don't worry. All right. So these are few things about the asthma, like symptom wise and common chronic, and few of these things are there. Now we are talking about, I mentioned that we'll come back to this obstructive and restrictive part. Why an obstructive lung disease is called obstructive? Next question. Why an obstructive lung disease is called obstructive? It is because, like, anything with the residual volume, anything with the total lung capacity, and anything with the word like, can I say the word air trap? Air has been trapped. Why obstructive? Because air has been trapped. Air cannot get out. So what will happen with the residual volume? What will happen with the residual volume then? So residual volume increase, total lung capacity increase. Okay. So these are some of the some of the criteria of the obstructive lung disease. Obstructive lung disease. This is another parameter. If you check with FEV1 by FVC, what will happen? FEV1 by FVC ratio. We're expecting it is to be reduced actually. Okay, often how much? Less than 70%. Less than 70% reduced. When you do the calculation FEV1 by FVC, it's reduced actually. Let's come to the restrictive, then it will be clear to you. It's not related to like a air trapping. This is a diseased lung. This lung does not have capacity. It's like important lung, Sorry if anyone has restrictive lung disease. All right. So this does not have capacity. Now, what about the residual volume? Residual volume decreased. Total lung capacity decreased. But here is the thing. FEV1 by FVC ratio. What will happen with it? FEV1 by FVC ratio, normal or increased. This is how the differences are: normal or increased. Can you see the basic differences? Yes, we can. So, and we can also write, yes, it is usually more than 75. It's 75 or more than 75. Everyone is clear so far? Why asthma is obstructive? What are the symptoms? And what are the obstructive restrictive? Obstructive restrictive related question you might see in the exam. Okay, next example is what are the example of obstructive to remember? I remember as a mnemonic as a ABC. I remember as a mnemonic as a ABC. Now, what is under the ABC? Under ABC, asthma, bronchiectasis, bronchiectasis, and another one is a COPD. So these three, my dear doctors, are ABC. These three conditions, ABC, are obstructive. Remaining all others, rest are almost all other rest are restrictive. Can you give 1, 2 example of restrictive? At least 2 example. At least 2 example appreciated. Okay, one. What do you think? Sarcoidosis, interstitial lung disease. Lot of research goes on in interstitial lung disease. One more, guys, that's also popular in the exam. Something related to occupation. Something related to occupation. Occupational lung disease as well. Okay. Under occupational lung disease, many things out there as well. Clear, guys? There's many other things out there. Fibrosis as well. Yes. All the rest you can put under there. Okay. Let's come back to John Mukta. Okay, let's see what John Murtagh has today. I'm trying to make it easy for you. In the beginning, see they mentioned inflammatory, and I want you to highlight. If you have a highlighter now, you can also highlight, or you can put a tick here, like inflammatory, respiratory symptoms, and this, that. And as we mentioned, there would be a risk factor related to asthma. So here is the thing, is the risk factors related to asthma. You have to remember it. So read about the risk factors of asthma. Risk factors is a very popular thing in the exam. Let me tell you, risk factor is a really popular thing in the AMC exam. Okay, coming to this one, these are all important. Other than that, you also have to remember separately the drugs causing asthma. So drug related to asthma, here's few drugs are there, but there are more drugs available actually. Let me tell you one thing, among the antihypertensive drug, other than the beta blocker, any other antihypertensive, it is yeah, this page number is 868. In the beginning, we already mentioned actually. Any other antihypertensive, it is not recommended. See, asthma has breathlessness problem, cough problem. So if you give a drug like ACE inhibitor, there will be more cough. When you cough, you can't breathe. So your asthma will be aggravated. Isn't it? So better to use what in that case? Better to use ARB. Better to use angiotensin receptor blocker. There was a question. I mean, some next day in the recall class, we'll see that question. There's a recall question regarding that. Okay, so learn separately about drugs causing asthma. There's like 3 given. You can also add the ACE inhibitor, but there are more drugs actually. All right. Moving forward, nothing much. You can highlight in the next page, immediate next page, 869 page, spirometry value. You can just highlight, but already in the picture I have mentioned what spirometry value, this FEV1 FVC value is here actually. This one looks more easy, right? Okay, going back here. So they might give you some scenarios regarding the FEV1 by FVC actually. All right. Now, MC would also like to ask you sometimes questions actually. Okay, let me ask you a quick question here. The quick question is here, the management regarding the asthma actually. So we have some uh, reliever and we have some preventer. Do you know which one is a reliever and which one is a preventer? Starting with the basics. Which one is a reliever? Which one is a preventer? So relief, salbutamol, often known as SABA. Okay, the preventer are like ICS, the steroid ones actually, the preventer actually, that's the basic actually here. Now there are a lot of delivery methods. They're like a inhaler device. They're like a nebulizer machine. Okay, so mostly we know about these things actually. Now, is there any other similar equal effective available? Like normally asthma treatment, we always understand by okay, nebulizer. Right. The emergency management. Is there any other similar thing which is also evidence based and it is a level A evidence? So nebulizer equals to spacer. Please remember this. If you deliver the, say someone call, you are the GP, someone called from the home doctor, my sister is having terrible asthma. You are the GP. So the hence we called. What you can do you have any spacer at your home? So try fix the inhaler device with that and just start giving like started with the giving puffs slowly and started with like a 6 puffs actually. All right. So that's the thing. So spacer are better actually. Now, a spacer using in different age group can be different actually. Now, a quick question: can a 2-year can use a spacer? Quick question: at a 2-year, are you expecting to use a spacer actually properly? No. What is the problem? I don't see any problem. My question was not inhaler device. Yeah, face mask. Please understand that one. My question was using. Yeah, you can give a face mask. All right. So that's the thing. So you can using a face mask. The answer is a yes. Actually, using a face mask along with the spacer, they can use it actually. So you can use it literally like a uh, giving the oxygen in that way. Okay. So that's the first thing. Can a 2-year can use a inhaler device? That's a big question. Can a 2-year can use an inhaler device like in a proper way? You know, inhaler using, you have to shake the inhaler, then, you have to take, you have to clear the lungs, then take. Can it 2 year? No, they can't take it actually. That's the thing. Okay, this is important actually. So be careful in the question. Are they asking about inhaler device? Are they asking about nebulizer? Are they giving about asking about the spacer thing actually? We have seen a lot of question coming like that. Okay, here is the initial particular thing. Okay, so here are a few things we just mentioned about the spacer. One condition, page number 870, it also came in exam in past. AMC also likes you to ask question regarding the associations actually. So also you will find it in Davidson. Davidson also is a good book actually. Before the AMC, I cleared the FCPS, so I had to study the Davidson um, almost like 12, 13 times actually. So I very clearly remember there was a chart that asthma has a direct 30% association, with a ZERT cases. Okay, ZERT cases. Someone asked a question: spacer nebulizer. As I mentioned earlier, it's a equal, similar efficacy, my dear. I mean, normally people think spacer is not that effective, but nebulizer and spacer has similar efficacy almost in terms of delivering things. Level A evidence. It is called a level A evidence actually. No, nothing is best. Both are called equal efficacy actually. Yeah, you might find researchers like, some might asking spacer nebulizer is more better. Someone asking spacer can more better. It's all about saving life, guys, actually, and it is called level evidence actually. Okay, Zina guideline for asthma. There's another guideline you can follow. It's Zina guideline, international guideline. Normally for MC, we follow RACGP, RCH, these guidelines. But for asthma, universally Zina guideline, GINA, Zina guideline. All right. Now, next one. So there's association question, spacer question, and this is how the spacer device looks like. This is how the spacer device looks like. Remember one thing, we started with like a kind of like a 6 puffs actually. Now, here's the kind of things are given. uh, Stepwise management. That stepwise management, I'd recommend to see the last one actually. Okay, so we are skipping this page because we have a at the end another stepwise management. We will follow that one, would be better. You can Google it for Zina guideline. Here you'll find it. Okay, here is the lines are given: preventer, reliever. Actually, you already know it actually. Now, I'll ask a key question which is tested again recently in MC. An asthma patient who is having emergency emergency. You give all necessary drugs. After 1 day, patient won't discharge. Isn't it very common in our practice? Immediately the patient get a little fine. They wanted to go home. Patient wants to go home. Please comment in the comment section. Is it common in your practice? Immediately the patient's symptoms are gone. Sir, we want to go home. We are fine. I said, still you are in danger. In dengue, chikungunya, it was a very difficult, very difficult to convince them. No, you are still not safe. I don't have any symptom. I want to go home. Very difficult for them to make them understand. I'm feeling fit. I can run. Please see, sir, I can run. And who will tell them that, this can, the shock thing can come later. Okay. Anyways, asthma emergency drugs are given one day. Patient wants to go home now. Okay. What drug mandatorily has to be present here actually? I'll give you a lot of options. Okay, options are the inhaler, definitely like reliever, ICS preventer, then there will be prednisolone, then there will be theophylline. So what do you think? Which one must has to be present actually? It's answer the drug of all drugs, and that is the steroid, and that is the prednisolone. I like to start a short story here. Actually, sometimes I try to add small stories. Uh, my specialty, I'm also um, gone through a lot of respiratory training in past. In one of the training session, one of my brother, he was telling, because we hearing the lecture from the professor, and he was telling, I wish I could save that patient actually that day. And what happened? So in the break, he said, like, because we all have relatives, right? In the village areas, they suddenly call actually. Nowadays, messenger, anyone can call. If you're not expecting, anyone whom you get connected, anyone can call actually. So anyways, he got a call, and again call coming. So he received and a village relative who's been calling and saying that, he's having asthma problem. So he said, I previously told you the asthma treatments, uh, take the nebulizer, take the basic things and this, that actually. Okay. So they said like things probably not working. So okay, just go to hospital. Now, my professor, why this line came up, my professor was telling, never ignore a night symptom of asthma. Okay. And it was a night call actually. And he was whole day he watched patient, and those people called around like 11 or 11:30. And then what happened? They didn't went to the hospital, and they are only trying the inhaler thing. Now, during acute phase of asthma attack, is inhaler is sufficient? When acute exacerbation is happening, when you try to take the inhaler, it just goes, or not does not always goes into the lung base. You need the uh, drug in your lung base. Actually, that's why a spacer is good. You can take it sustained way. It will slowly go at least, or nebulizer as well. Okay, but some cases those are also not enough. It depends on how big is the attack. And the next morning, the report came, the patient died. And he was, you know, scattered, like, that because, these things, uh, he feels like, he was murdered and this, that. And Professor Silling, never ignore a night symptom and always give a prednisolone tablet actually to the patient. So he realized he didn't prescribe that because prednisolone tablet available everywhere, even in the village pharmacies, isn't it? Even in the village pharmacies, at least steroid tablet would be available for sure, actually. So he said, like, okay, take those drugs I've told, and this, that he ignored actually. And another mistake he does, it was a night symptom of asthma. So that's, I'm just repeating what my professor said actually in that respiratory course, that, never ignore a night symptom of asthma ever with a patient. If you do not take risk, because whatever you are saying, patient might not follow. So make sure at least steroid is there actually. There's no harm in giving a short course of steroid, no harm. Yeah, in that way. Rather, you can save the life. Okay. So never hesitate giving the prednisolone. Okay. Clear everyone about this thing? So never ignore the night symptom. Yes. So prednisolone, often the lifesaver, prednisolone is the drug of choice, even you are discharging the patient. So drug of choice, and also while you are discharging the patient actually. Okay. Please note, sodium chromoglycate is also is a preventer in pediatric cases. Lot of pediatric cases you will find, and next day we'll have a recall class. So in that recall class, we'll find that you know sodium chromoglycate often used as a preventer actually. Sodium chromoglycate often used as a preventer actually. Guys, I mean about note things you can contact later. Please focus on the class actually. It looks very harsh actually right now. Should I take a class or should I talk about a note actually? Okay. So if anything is there, please contact after the class. We'll take your complaint and things actually. Okay. So here is the thing. Now your job is to listen to the class actually. What was the question? The question was, so that you don't forget, uh, SCG, sodium chromoglycate. It is a preventer. Can you name some other preventer? Okay, so the popular ones, sodium chromoglycate, right? Then ICS. Now, is there any age-wise something? This is a very popular in the exam actually. Is there any age-wise anything you can use? So there is a cutoff value like a 5. Okay, we put a cutoff value like a 5. So we say usually like that below 5 years. I repeat, below 5 years, we try to use the sodium chromoglycate SCG, and above 5 years, we try to use the prednisolone or the corticosteroid. Okay, now question is why the steroid after 5 years? Why steroid after 5 years? That's the question. It is because if you give the steroid in the early, I mean, there will be growth retardation, more chances. Okay, so there will be chances of growth retardation in that case. Clear, everyone? I hope yes. Okay, this is one very, very important information. You will see one more thing. This information for the next day class, you will see how lot of information I'm giving would be helpful when I'll be taking the second class, question solving. So my classes are based on the exam specific actually. A lot of other side things I can teach. I'm being also belong to respiratory community. I can also tell you more things about respiratory, but I think it's more appropriate if you know about exam oriented things actually. Otherwise your syllabus would be huge and huge actually. Okay, available inhalation, available in the form of inhalational route. So I saw a recall, which is means past paper. A lot of people are discussing no sodium chromoglycate. Why as an inhalational route? Inhalational route means it's a ICS or those things. Okay, so they're choosing ICS on a 3 year because they thought sodium chromoglycate not available in the inhalational form. Okay, so clear this doubt. Sodium chromoglycate also available in the inhalational form. So let me show you here as a sodium chromoglycate. Um, it is also available as a nebulization or inhalational form. Is it clear now, everyone? So you'll find a question next day regarding this. This information is very important. This is a cream question in the exam. Actually, if you know, you know. If you don't know, you don't know. All right. Moving to the next segment. Okay. There's another thing. Stepwise management at the end, I will tell you again in general. So don't worry about it. Next another topic is a exercise-induced asthma, page number 874. Okay. Now, in one word, these lines came that, someone from the very beginning of life, they have asthma. Now, my first question, someone is having exercise-induced asthma. Can they play football with other kids? Quick question. Exercise-induced asthma, can they play football? Are they allowed to have a normal life as like the other people? Answer is a yes, absolutely. And you need to give the kids that idea that, see, you just have a small thing and you just need a little adjustment and you are totally like others, because kids' mind is a innocent mind. Now, there is a word, it came as in that way. What is the best treatment for exercise-induced asthma? Now, options are SABA, like salbutamol, montelukast, or sodium chromoglycate. Now, which one do you think is the best treatment? Now, for that one, I have to take a little help from one of the, uh, yes. This particular thing has been taken from RSCGP. And in that RSCGP, you can take a screenshot of this one. Perhaps it's available in our notes section as well, but maybe this one you can take a picture. So this is RSCGP or RSH guideline. So exercise enema best managed with the inhalational route with a, you can see this one, beta agonist. Is it clear? So best managed SABA. Is it clear? Okay, we have to follow certain things according to Australian guideline. So few of the things might contradict sometime. In that case, we can clarify from the Australian guidelines. How does exercise, like it is a particularly exercise can aggravate asthma. So very common actually exercise-induced asthma it is called. It is an individual term, my dear. If you don't know about it, I mean, you can check this one in the John Murtagh. It's a specific thing, categorized like a cough variant of asthma. Exercise-induced asthma, they put it as a separate category actually. When they go for not only exercise, any exertion, better to say exertion-induced asthma, any exertion. They are taking a lot of steps. They're going to the hills, they'll have asthma. They're going for a running, they're having asthma. They're going for swimming, they're having asthma. Okay, it's kind of like that. Clear now? Okay, so assessing asthma, just in one word, best managed by SABA. Just write this thing in your journal. Best managed by SABA. And you're done with a one question in AMC. Okay, moving forward. Yeah, so here is a asthma action plan. You can have a look on that one. So asthma action plan, you can also read it, more popular in the AMC part 2 exam. Actually, you have to explain this thing actually. Okay, there was another question. Someone is coming and complaining about um, the SABA was given to a asthma patient. Okay, and patient is complaining it's not working, not working. So what will you do? Adjust the dose, new drug, or give a combination, or check the inhaler technique. So there was a question like that. So which one do you think would be better here actually? Final answer would be here. Double check the inhaler technique. If you see in YouTube, there's a lot of funny videos on, inhaler use. One I found in that way, in one of the chamber, someone came and we asked to, okay, show me how you use the inhaler. All right. That time I was training. So professor said, okay, come and see, how this patient is using inhaler. Okay, please show. And he's giving, encouraging him. Now he took that, some inhaler device, and he's pressed like, just pushing like, like a scent, like a perfume. And it is so common. It's not like in YouTube videos. In real life, we have seen that one thing. Okay. So the next things are even more things. I know whether they are clearing the lungs, then they're putting this thing. This is a common mistake. But before that, they're, putting as a just like a perfume actually. Okay. So also patient exists like that. So your answer would be here. There's a lot of MC questions are kind of like that. You will think, oh, that's the answer, but there's another better option. So check the inhaler technique. Clear? Okay. So check the inhaler technique first. I'm trying to give you the information which has been tested in MC. Now, one of the coming thing is a acute severe asthma management actually. Now, in general, can we just write the management and the treatment? You guys also try to participate. It would look nice. Okay. The first started with first of all, hospitalization, then propped up position, oxygen inhalation, then what? Okay, after that, oxygen by mask, then nebulization. Nebulization. At home, if it is possible, they can use the spacer. Remember always, the patient can die from asthma always. It's always possible. So hospitalization, propped up position, oxygen inhalation, nebulization. Okay. Then what to do? Then IV hydrocortisone. Okay. You can also use the tablet prednisolone. Then you can also use, if these are not working, aminophylline IV, aminophylline in a drip IV. If you're giving aminophylline, you should check the blood pressure very carefully because it gives rise to uh, low blood pressure actually. If still all these things are failing, if all these things are failing, I mean, there's an option to go to ICU, but before going to ICU, there's another thing you can try. before going to ICU, another thing you can try. By the nebulizer, you are giving the SABA actually. Sorry for mentioning that. Maxsulf, okay, agreed. Maxsulf you can use. Adrenaline, yeah. So same thing. I mean, adrenaline basically you have to use in ICU in any way. That's the thing. Okay, so these are the particular things to remember. Clear everyone about the asthma management. This is acute asthma basic management. Acute asthma basic management. Now, in order to give the treatment of acute asthma management, you need to also assess them properly. Okay, so there is a chart. I mean, this chart I took from Davidson. Anyways, you can find it at Davidson, or you'll find it on our SMA note. SMA note, there is a asthma note is there. You can find it. I mean, don't text me now. You know where is SMA notes actually. I mean, we are in a class now actually. Okay, immediate assessment of acute severe asthma, as you can see, acute severe asthma, life-threatening asthma, near fatal asthma. Three categories: acute severe, life-threatening, near fatal actually. Now, what are the differences? Are we expecting inability to complete a sentence when there is acute symptom asthma? Yes. So inability to complete sentence, common in all the cases, inability to complete a sentence. Heart rate is high, respiratory rate, of course, more high, more than 25. And peak flow, there's a device, peak flow, if you can check it, the peak flow gets down to 33 to 50%. Okay, so these are the initial category or criteria for acute severe asthma. And acute severe asthma management, I just now mentioned. There's a more situation can be bad. Now, patient can develop cyanosis. Is that a good news, guys? In a asthma patient, if they develop cyanosis, it's a not at all good thing. Let's say compare contrast. I use this word often. In a kid's case, of course, cyanosis is bad, but in kids' case, sometimes we see the word grunting. Have you heard this word before? Grunting. And in AMC, they often use this one in the exam, the word grunting. Grunting is not a good situation. It's a very bad situation. Okay. If the word grunting is there along with the other clinical scenario, the patient's situation is not good. Whereas the cyanosis is also kind of like the same. Silent chest, cyanosis. If these lines are there in your exam, you will understand patient is in a life-threatening situation and saturation is below 92%. Did you remember during COVID days, what we used to tell the patients? If your saturation is below 92, please immediately get back to the hospital, isn't it? Okay, so below 92 is a life-threatening. Below 92 life-threatening. Because in during COVID time, we don't have the space even during in the hospitals, right? How many of you are COVID doctors, guys? You can remember this thing for your life. And how many of you treated COVID patients, guys? I think most of them, I guess. All right. Even not a medical student, they also participate, because there's shortage of hands. Such a situation. We never want to see that kind of thing. Anyways, so below 92 was the parameter during COVID as well. All right. Now, this one of the particular thing, I'm going to tell you something very important now. All these things are happening like this in oxygenation less, this, that. This situation is called hypoxemia. Is it clear, everyone? This situation is called hypoxemia. If hypoxemia is present, what type of failure it is called? It's a counter question to all of you. If someone has symptoms and oxygen level is that this is a hypoxemia is present, is it a type 1 or type 2 respiratory failure? It's a type 1, my dear doctors. Type 1 respiratory failure. Now, for type 2, what else to be present? Okay. First of all, hypoxemia has to be there, but there's another criteria you are expecting. That is hypercapnia, means carbon dioxide level has raised in the body. Carbon dioxide level has raised in the body. Like say asthma COPD, normally type 1 respiratory failure. But extreme cases of asthma COPD are type 2 respiratory failure cases. Is it clear, everyone? Normally, asthma COPD, these are type 1 respiratory failure. But extreme cases, carbon dioxide level increases, then that becomes a type 2 respiratory failure case. Okay. Now, here is the thing. The near fatal asthma, raised hypercapnia. Can you see that? Very small, but I hope you can see. Raised PSCO2 and requiring mechanical ventilation. So there was a question in MC, what is the indication of mechanical ventilation in a asthma patient? What is the criteria of a mechanical ventilation in a asthma patient? So there were some criteria given. One of the criteria was a hypercapnia. So do you agree? Hypercapnia is a direct indication of a mechanical ventilation in asthma patient. Clear now, everyone? I hope it is a yes. Okay. Good. Yes, those yellow headlines are important, my dear. These yellow headlines are important. Yes, that's why they are marked actually. It means they have been came in last few years actually. Another level evidence. I mentioned this one, spacer or nebulizer. Is it similar? I think you all must be agreed. A spacer and nebulizer, similar level evidence. Okay, so please mark this one. Also, danger of asthma. Here are the symptoms of asthma. Danger sign of the asthma. We just show you the acute, severe, life-threatening, and near fatal. And near fatal related, one of the question we just discussed with you. All good? All right. Asthma action plan, you can check from that chart. We're taking you to another thing, puff related confusion actually. Okay. All right. Now you can see initially I mentioned like normally you should start in a uh, 6 puff kind of, right? 6 puff of salbutamol actually. This is the basic and the standard. So very popular one of the question. Next day you will see this question in the question, then it will be more clear. Now it will be very difficult for me to make you understand. We usually start with 6 puff for all. We usually start with 6 puff for all actually. Okay. So if it is not working with 6 puff, I repeat, initially you started with 6 puff, the person's age is 4 year, and you started 6 puff, it is not working. What will you do next? You'll repeat the 6 puff again, or you will go for a 12 puff? That's the question. So this is a puff related confusion. So here's some information. If below 6 years, you can mark this line, page number 878. Very important, very important this section. It's like a 4 year. The initial is always 6 puff. Okay, no matter what age, initial is always 6 puff baseline. Then comes if it is not working, because when acute severe asthma sometimes started not working, then what to do? So if it is a 4 year person, which is means below 6 year, you repeat 6 puff. Okay. Now question is, if that person is 8 years and you started with 6 puff not working, then what? Then it would be 12 puff. Clear? This thing clear, everyone? Initial is always 6 puff for both cases, but under 6 year it is repeating is again 6 puff. Over 6 years, 6 or over 6 years, yeah, it is 12 puff. All good? Yes. Great. Write it down, memorize it if you don't understand actually. Okay. If your question is, why this is given, this is how the managements are made. Yeah. And imagine as a uh, the 8 years person is a more uh, well-built, they need more drugs in the body. Think in that way. Okay, I think that would be clear. Okay, so asthma in children, we have been discussing adult and also kids variants of the asthma. Here's something about the nebulizer and asthma MDI inhaler using is given. So you can see inhaler use even in 5 years is a difficult. So 8 years or over is more recommended. The typical inhaler we are talking about. Okay. If it comes about the using the face mask, even if you see under 2 year, it can be used. Did you see this thing? That under 2 year, um, inhaler with a spacer with a face mask on, you can use it actually because it's just like a mask then for them. Okay. If it about only spacer, then you can see it has to be over 2 years actually. It has to be over 2 years. Okay. Is it clear, everyone? Is it clear? Using inhaler with spacer, using inhaler with mask. This is the chart. Previously mentioned, now again it came up. So be careful during the exam. This will come up actually. Okay. Now we are heading towards the stepwise management of asthma. This is the last segment of the asthma. Okay. Stepwise management of asthma. Can you see that? Now, categorized as mild, moderate, severe. I want to add in another category here. Okay. Occasional asthma. Maybe some of you also have occasional asthma. Like sometime it flared up. It is sometime flared up. Is there any type of asthma? Is it there? Like seasonally, sometime it came up for some people. Have you noticed things like that? Like sometimes some people occasionally suffer with asthma and they just use the salbutamol that particular time and they are fine after that. Okay. So you can also put a category, not only mild, moderate, severe, like a occasional asthma. It's also handbook question. So occasional asthma, you also treat occasionally. Is it necessary to continue salbutamol regularly? I repeat, is it necessary to continue the salbutamol regularly in occasional asthma, like every day to day? No, it's not necessary. Okay. Now coming to the mild cases. So mild cases, infrequent episode, attack is not severe. Okay. So things are given like that. So 6 to 8 weeks apart, and you need to continue using the salbutamol. Clear everyone? Continue using the salbutamol. Very important things are the weeks, if you see. More than 6 weeks. That means more than like a 2 monthly, if you're having attack, that means you are having the mild one. But if it is below 6 weeks, if it is happening below 6 weeks, or roughly speaking, like a monthly, if it is happening, now it means your drug is not working. Is it clear, everyone, what I just said? If you're using salbutamol, and you are having issue every month, is your drug is working? If you're using salbutamol and every month you are having an attack, is it working? It's not working. You need step up. So you are suffering with the moderate. It means below 6 weeks, if it is happening every monthly, if it is happening, means it's a moderate. Now only SABA, not enough. So what to do? Give ICS. Clear now, everyone? So along with SABA, that is how the ICS came up. All good? Yes. Now, even if it is becomes more severe, now you are having weekly attack, including the night symptom, weekly attack and also the night symptom. Now only SABA and ICS, is it enough in that case? Not really. You also need to add the oral prednisolone. You also need to add the oral prednisolone in that case. Okay. That's the important thing. Yes. All right. So mild, moderate, severe. Mild case, SABA. Moderate case, SABA and ICS. Severe case, SABA, ICS, and prednisolone. Very simple, stepwise management. Mild cases, over 2 monthly, there would be attack, like more than 6 weeks. Moderate cases, below 6 week attack. Severe cases, weekly attack. Okay, severe cases, weekly attack, including night symptoms. Now clear? I hope that's okay. You need to improve also your catching power some cases, guys. Yeah, important. Okay, all right. And here is that information earlier I said about using a prophylaxis, separately talking about this topic. Sodium chromoglycate up to 5 years, fluticasone when more than 5 years. Okay, there's another. Yeah, this is the thing. All right. Yeah, there's an option of lava. Like you can use a lot of things as a combination actually, but you need to add the prednisolone. When it is severe, it's basic actually, So remember those points I'm saying, it would be helpful actually. So asthma is a very big thing, combination after combination after combination. But when it's very severe asthma, you need the prednisolone. You see, already I give a summary that someone life was held. Yeah. So SABA, ICS, and then you can also consider LABA as a combination. Yes. No worries. All right. Okay. Done with asthma, going into the COPD. So in that case, before starting COPD, there is a chart about which I started early in this chart, if you remember something. Yes. Yeah. So this is something we started earlier. Yes. So trying to discuss something about asthma versus the COPD. Oh, someone asked a thing, good question actually, I would say. Does doses are necessary for AMC to remember? Absolutely no. Okay, absolutely no. You don't need any doses to remember. Okay, is that a good news? Okay. How many of you feeling relief? Yeah. Like, in MBBS, they used to torture us with these doses, actually. Yeah. Because that time we were not practicing. So how would I know the doses properly? Okay. That's the thing. With exception, like some cases, B string cases. Yeah. One or two, I mean, which I will tell you actually. So one or two cases, like I, nebulized adrenaline, 1:1000. All right. Would recommend if you're attending class, you are using, like a sitting on a table and things like that, like not like a sleeping, like those of you are trying to sleep during the class is already one step towards the graveyard. I mean, sorry, towards failing, Yeah. Anyways, so just be attentive during the classes. I mean, I'm equally also having, see, I'm talking, you are listening actually. So I'm probably having more pressure than you. Okay. So you can, for your sake, you can sit in a table chair with a laptop, sit properly. Yeah, don't go to sleep actually with a mobile device actually. Yeah, we'll go for a break. After finishing the obstructive, we'll go for a break. Okay, that's a promise. Okay, it will take just 10 minutes, 5 minutes for the COPD, 5 minutes for the bronchiectasis. All good. Then we'll go for the break. You good? Yes. All right, thank you, my dear. Now, coming to this one, because COPD is a comes very less in AMC, and if it comes, it's very straightforward. The COPD thing. Can I say something about COPD? COPD is almost similar like asthma. Agreed, guys? COPD almost similar like asthma. Okay. Now we need to find out where are the differences. We need to find out where are the differences. Then the differences, I would say, age. Asthma developed in early age. You know the person is having asthma is often in the childhood. Some cases environmental, occupational, that's a different thing. But most asthma cases we know from the beginning they have asthma. And COPD developed after 40 or after 45. Another common thing is a smoking thing is available. Okay. So those of you who are a smoker, there is a chance you can stop. There's a good news I want to share that if you stop smoking just below 40, all the changes in your lung will be almost totally reversed. Now, is that a good news actually for the smokers? And I shared this information with my smoker friends. So the ha ha ha. See, we are enjoying this cigarette over the years. Okay, we'll drop it. But you didn't enjoy the cigarette, Okay, so that's the thing. So it's a good news. So if you do that below 40, in that case, it will be totally reversed. And then they're saying that, okay, we have enjoyed our life. You did it. Okay. So good information, good news for some people, actually. Still you have a chance totally to reverse, actually. But it's not like you immediately stop, everything will be reversed, but it will be almost fully reversible. It would be. If you haven't gone through up to the COPD, your changes would be reversed. Okay. So after 40, smoker, these are common things. Uh, there is a some gland hypertrophy happens. That's why there is so much cough is produced. And when you are sleeping relaxed, the glands working more. So more cough came out at the night. So early morning, you will find a COPD patient in the toilet taking too much time, and you heard they're just coughing and coughing and coughing, just clearing the lungs because overnight, that's the thing. Okay, so this is something. And cough being the prominent symptom over the breathlessness. So cough is the major symptom for the COPD, but of course, breathlessness would be there. For asthma, breathlessness is somewhat the main thing actually. And the wheeze, musical sound, this, that actually. Okay, otherwise quite a similar. Quick question. Is it important when a asthma patient came with a breathlessness, I would like to do a X-ray? True or false? This is another exam question actually. Patient with asthma come to you, what test you wanted to do? Okay, X-ray was there in the option. I picked up X-ray. Is it a right answer or wrong answer? Of course, it's the right answer. Why not? I don't know it's asthma. It can be pneumothorax. Mark it. It can be pneumothorax. Practical thing, guys. If someone coming with a breathless, you cannot always guarantee that it is asthma. Exclude the DD. It's important actually. Some cases, if you're you are his GP, You know everything. Last week the person has an attack, and now again. So you can always do an X-ray, in emergency if you feel it's necessary. You can see the pattern. You can put the stetho, reduce breath sound in the affected side. Definitely you need an X-ray immediately. Okay, so here's some symptoms of the COPD. So yeah, so things can be hypertension. You can see the X-ray looks more black in the COPD. Okay, that's another thing. And we have already discussed about the APV on FVC. Now I would like to tell about a twist here actually. So far, are you agreed? Both of them are obstructive lung disease. So FEV1 FVC would be less than 70%. Agreed, guys? Is this thing clear till that? FEV1 FVC, both cases, it would be less than 70%. So now the game begins. Now, as a new game. Yes. Now here is a thing. FEV1 FVC less than 70%, both in asthma and COPD, right? Already mentioned. Now there is another test we can include, which is the confirmatory test. Now, what is the confirmatory test in asthma? What is the confirmatory test in asthma? So have you heard about a reversibility test? Reversibility test or post bronchodilator test. So you'll give the puffs of salbutamol. You'll give the puffs of salbutamol and see how much changes. Now, how much changes you are expecting in asthma? Say already the FEV1 FVC is 55. So at least how much it should be? If it is given 55, at least 15 it would be changing actually. So 55, 5, 60, at least 70. So 70 or more it would be. Is this result is same for COPD? Not same. Okay, they will have a 2-3% of change only. Clear now, everyone? So this is one of the things. Salbutamol is one of the mainstay of the treatment for asthma. Salbutamol is one of the mainstay of treatment for asthma. That's why it does not work in COPD in that way. What is the main treatment for the COPD? I mean, drug-wise, the treatment is kind of similar, but drug-wise, what is the main thing? So the drug-wise, the main thing is um, the cholinergic. Okay, so if you just see the anticholinergic are the mainstay for the COPD cases, not the salbutamol actually, like ipratropium, yeah, and this that. Clear now? I hope that's clear actually. So reversibility test is positive in asthma. There will be 15% deviation. There will be 15% deviation in asthma. In COPD, no 15% deviation. Okay. Drug used in reversibility is a salbutamol. Salbutamol is a short acting, which works very well in asthma case, but does not work very well in a COPD case. Now, is it clear to everyone? Asthma, COPD, fully clear, everyone? Asthma, COPD. Okay, I'll just take over the screen to show you something, our MC notes. Okay, COPD. Okay, I just opened something with the COPD. I opened our SMA node. Long smoking history, barrel-shaped chest. This is how one of the question came. A long back actually. Long smoking history, barrel-shaped chest. What you are expecting? Which respiratory condition are you expecting? But it's definitely expecting a COPD case. But barrel shape, mark this for this often given in the exam actually. Okay. Now, differentiating point asthma COPD is already discussed actually. So breathlessness is more predominant in asthma. The family history is more common in asthma, more than 40 in COPD. All right, so we already discussed this part, and this chart we have seen. Yeah, it's already there. And COPD, yeah, it's already mentioned FEV1, FVC, and the drugs. I like to add one thing. There was a question with COPD. They give you some drug names, but another option was mention stop smoking. What do you think? Which one we should choose first? Actually, what is the next appropriate step in the management? That was the question. In the question, stop smoking, salbutamol, anticholinergic, ipratropium, all these things are given. Answer was stop smoking. Okay. COPD cases, please remember, before starting anything, stop smoking. Clear? Smoking, not cessation, is stop smoking. Yeah. Smoking cessation is always not a good idea, actually. Yes. Okay. So you can check that one. Yeah. For some of the COPD related information, actually. All good? Okay. So this goes. I'm just taking the screen to show something on the bronchiectasis. Okay. So I just opened the something related to bronchiectasis from our notes section, because bronchiectasis is not given properly in the John Mott. Okay, so you can follow that note. Okay, so do you remember the definition? Abnormal and permanent dilatation. Is this two word? Yeah, this note is available to, I mean, to the those have already joined, right? You need to study John Murtagh, you need to also study my notes because notes are crunchy. So during the exam, can you read the whole, can you revise the whole John Murtagh? A very basic question I'm asking. Is it easy to revise a whole book before exam? No, right? It would be very difficult. So that time, you can quickly just go through the notes actually. Clear? I mean, why notes are important? Because before exam, you'll be crazy. You know, you can understand all subjects together. Yeah. No, I mean, while studying, it's also easy. You can see they're concise, nice. So it's also easy. But uh, to go a little bit more faster and to avoid little boringness, notes are good. Note you can always open. You can open from your mobile. You can open from your laptop. This notes will be there with you. Till exam. So you can always open even while driving, while in a train, in a bus. You can just keep checking. Right. Okay. Have you heard about this term about bronchitis? This is an obstructive lung disease. So I don't want to go into the criteria of obstructive lung disease. Have you heard this word, abnormal and permanent dilatation of bronchi and bronchiole? Ever studying the MBBS? So abnormal and permanent. So this is a reversible or irreversible? I'm coming to you actually. Is it a reversible or irreversible? What do you think? So bronchiectasis is again irreversible. COPD is again also irreversible, but asthma was reversible. You can see. So this is a permanent damage to the lung. And when there is a permanent damage to the bronchi and bronchiole, are you expecting a lot of infections, guys? In that case, are you expecting a lot of infections in that case? Yes. So see, bronchitis case is one of the cases is patient you will find taking a lot of prophylactic antibiotics. Yes, well done. You will find the patients to be taking a lot of prophylactic antibiotic actually. All right. Okay. So you might give in a CT scan in the main exam. So you can see there's a lot of mucus being produced. Okay. So a lot of mucus should be produced in a bronchitis case. So cough will be one of the cough, later hemoptysis. So cough is again one of the major thing. Cough will be one of the major pro issue. So the clinical feature, persistent cough, as like kind of similar like the COPD. So persistent cough and sputum, repeated respiratory trouble, wheezy breathing. Okay. Any anytime your airway is narrow, there will be musical sound and coughing out blood at some point. It's not so common, but scary moment when yeah. So that's the thing. And there can be clubbing. Have you ever heard one of the cause of clubbing is a bronchiectasis? I'm sure yes, many of you heard. So you can see the symptoms and this, that, and all right. Great. Is it possible bronchiectasis, COPD, this particular condition can lead to right heart failure at some times, particularly COPD. I mean, have you ever heard about this thing? Like a term called cor pulmonale. Okay, so please keep it in mind. Mainly COPD, they can lead to heart failure as well and lead to cor pulmonale. This is a tested topic in the exam. Okay, next we will see that one in the question, how it comes, how it tested. So abnormal and permanent dilatation of the lung. By the time you will finish the AMC, your brain condition would be also kind of like this. Just a joke, but you can ask some of the other candidates while going through MC1, MC2, you will feel like nothing left inside you. Okay. Now, as we mentioned earlier, that CT is very popular. So if I highlight, you see abnormal and permanent dilatation of the bronchi and bronchiole, very clear. Yeah, some cases tram track actually. Some cases tram track. Focus on the note, my dear. Bronchiectasis is not given well in the John Murtagh, recommended to follow from the notes. So this is the X-ray of bronchiectasis. You can see some chronic lesion sign. Mainly the CT scan will be given. Abnormal and permanent dilatation actually. Okay, so abnormal permanent dilatation. Even cystic fibrosis, they can also have bronchiectasis. Clinical features. So it is nearly impossible to diagnose bronchiectasis without an imaging. This picture and this page I took from a book named Mastered the Board. Okay, so it's also a good book actually, medicine. Some things which is not present in John Murtagh, you can always check from the Mastered the Board. Don't worry, we'll post that book in future. So most accurate is the by a CT scan. Now, coming to the treatment of bronchiectasis, of course, you need a antibiotic, prophylactic antibiotic. During symptom, you need oxygen, nebulization, salbutamol. But have you ever heard about a condition, even in COPD, even in bronchiectasis cases, chest physiotherapy? Yeah, tram track line, but tram track always does not follow. Okay, unless if it is too chronic, some cases it becomes tram track. Okay, that's my explanation about the tram track. Or you can Google it about the tram track in bronchiectasis, you'll find it. So chest physiotherapy or incentive, yeah, uh, chest physiotherapy. So this is the important thing. Okay, so rotate the antibiotic one weekly each month. So rotate antibiotic. And also there's surgical option also available actually. So chest physiotherapy, very helpful. Okay. So it is a difference about feature imaging and some of the pulse are given. You can have a look later at your convenience from the differentiating point between these three. And finally, the treatment, yeah, as always, chest physiotherapy, antibiotic, bronchodilator, physical exercise, and surgery in very severe cases. Okay, so that's from the COPD. Mainly, let me tell you, it comes as a CT scan. Clear, everyone? How bronchitis is tested in AMC exam comes as a CT scan mostly. All right. So we'll go for a break as per some of you requested. And yeah, so let me just have a look. Yeah, bronchiectasis, if you want to check in John Murtagh, it's given in page number 379. Okay, just for more information. I mentioned in that one, you can also mention it in your John Murtagh. This is the problem in John Murtagh. Sometimes different things you might find in different pages. My job is to help you arranging this thing. Okay, to take some of your pressure on me. So bronchiectasis, abnormal permanent dilatation, predisposing factor like they can have infection, they can have foreign body, cystic fibrosis, cartagener. So mainly again the same thing, CT scan. CT scan is the main thing. Sputum production, and yeah, you need that CT scan. Bronchial wall thickening. Okay, and treatment already mentioned. Rotatory antibiotic weekly for a month. Chest physiotherapy. Uh, Tell the patient try not to get infection. So using a mask, whatever, try to do, don't get cold. We tell them it's difficult. It's to keeping always staying at home. So, but anyways, okay. All good, guys. So this is the end of the obstructive lung disease. When we come back, we'll start with a lung cancer afterwards. So lung cancer, mesothelioma, these three things coming up. Then we'll get into the restrictive lung disease like sarcoidosis. Okay, those things will not take that time. Asthma was the biggest and more question tested always from the asthma. Let's go for a 9-minute break. Okay, everyone. So thank you so much. Let's have started. Okay, so these are the coming up topic, and we are getting into the topic of lung cancer. Please do let me know in the comment section what you have done in between the break. Um, subject to go away. I mean, that's the part. Like, see, classes can be a little long. That's one of the secret that many of our candidates they do well. Uh, because I have the strength to hold on longer classes, and you will get habituated with that one because your exam is also kind of similar time, like 3.5 hour of exam. So if you uh, keep having this habit regularly because you are not habituated with 3 hour classes, right? So if you'll be habituated with that thing, you will do well. You'll put up well in the main exam in that case. Is it clear, guys? So please try to have that one, even though we'll be uploading the recording. But please, my request, try to have the classes till end. This will be like a mental preparation for the AMC. Okay, you will not understand, but this will automatically will become your preparation and your habit. Actually, like 3 hour things you can hold on. Yeah, that's the thing. Those will be habit of okay, recording will come up, we'll be seeing it. They will be in real trouble in the main exam. Okay, a minimal thing people can fail in the main exam. Okay, let's come and focus on this one. This is the topic that is coming up, like uh, bronchial carcinoma, lung cancers, right? Like this is the main thing, the lung cancer actually. All right, please open up your John Murtagh 395 page. Okay, 395 page. Recommended to open up, and this is how it looks like actually. The coming up pages. I'll be showing the notes in a second. I'll just take away the screen just to bring the note of lung cancer. Take one thing in that way, I'm working even more harder than you. Okay, because I have to take a class and you're listening. So someone who is taking the class is even more difficult. So you can always stay in the class. Okay, so lung cancer related to SMA related, no. So must learn what to study from the lung cancer. Okay, for AMC. Very important about the investigations actually. I mean, we'll initially go through the clinical symptoms, like what are the symptoms if it's a cough, like then some symptoms because of the compression, hemoptysis, weight loss. Okay, those are the things. Few things are paraneoplastic symptom, we'll be discussing those. And there are a lot of types related to lung cancers. Okay, so that's very common, and type related question will be also very common in the main exam. So these three are the primary focus in MC, that from these three area your most of the questions will be tested. Are we clear, guys? I mean, please comment in the comment section. Are we clear? Like, how, I mean, you see, I'm always trying to convey the information which is more specific for the exam. I can go into more pathophysiology, more detailing thing. Uh, in that case, things would be more longer and you will lose interest at some time. People, I believe, mostly looking forward to exam related classes. All right. Exam oriented. I mean, see, the lung cancer related, when I was teaching MBBS student, I took like 3 classes on lung cancer actually. Okay, so even 3 classes on lung cancer, I can imagine like so many informations were there actually, because that's a different thing. But here, so many diseases you have to learn, even a lot of rare diseases. So it is very, very important that the exam is specific. Okay, like things has to be effective for you. Okay. So you'll have pain, some cases breathlessness, some cases coughing. So these are the symptoms. As I said, cartoon is always nice technically. So coughing, weakness, breathing problem. Eventually you'll have weight loss. Okay, so these are some of the main things. Weight loss being one of the very prominent thing in, yeah. Next thing is about the lung cancer. I was supposed to draw, but it's okay. It's been drawn actually. Okay. You can see the lung, the black color I just to draw, and these are the bronchus and bronchioles I'm trying to drawing here. Now, there's two lesion of the lung I try to put on here. One is the red one, okay, which is more centrally placed. And one is the more in the peripheral side. Now, my next question is coming to all of you. Which one is more symptomatic? There's two you can see. One is a red and one is a green. So which one will cause the symptoms more early? The answer, the one that is centrally located, better word to say, which is near to the bronchus, will show the symptom more early. Clear? Now, which one is more dangerous? Imagine a enemy which you know is better or enemy you don't know is better. A known enemy is better rather than, the unknown enemies are more dangerous, right? And we all have this thing in our life actually. So unknown one or even can be more dangerous. You don't know. Maybe someone is near to you and don't know that that person is enemy is even more dangerous, right? Have you gone through this kind of thing while studying in a school, colleges, medical? There's a lot of, you know, backstabbers. Yeah. So anyways, they remain silent at a time, they show their color. Now, here is the thing, the green color is kind of like that. Yeah, like snakes. So the peripheral one, this slowly develops in your lung and they become big, big, big. At some point, they came up. That time it is too late, isn't it? So imagine those friends, whom were the silent killers are this green color of the peripheral lung cancers actually, and they remain asymptomatic. And then when they show up, it's become very inappropriate or dangerous for you actually, right? So peripheral lung cancers can be more dangerous. Agreed, guys? So peripheral lung cancer can be more dangerous because they remain asymptomatic. Central lung cancer, we know at least in the first hand that there is a lung cancer, right? Now coming to the types of the lung cancers actually. Okay, some of the types related to lung cancer. Now let me try to make it bigger for you. Okay. So first, starting with the squamous cell carcinoma, adeno, small and large, and there's a metastatic one as well. Which one is most commonest type of lung cancer if you are asked actually? Because this kind of question is also very common in AMC. What are the various types of question that comes in the exam? All right. If I may show you something. Okay. Uh, how things are tested in AMC? Because a lot of people are taking class, they may not come to the course. Just understand one thing, how many different way AMC test questions. One, they'll give you diagnostic thing. Okay, they'll give you scenario, you have to make a diagnosis. They'll ask you also for investigation. They'll give you scenario and they'll ask you initial, next, and the best. They'll also ask you for management and ask you for initial, next, or best. Okay, they'll give you scenario and you have to choose the managements. Some cases it can be best approach. They mix up investigation and they mix up management and they're asking you pick up one, either investigation pickup, either a management pickup. So I'll show you in coming days in the recall classes regarding that. Okay, so there's an interesting one. Also, a lot of way MC test you statement type of question. This is test of your depth of knowledge. Like say, which one of the following is true about squamous, about small cell carcinoma of the lung? They'll give you 4 or 5 statements. Some are statistical, some are symptom related, uh, like breathlessness is the primary symptom, or weight loss is the primary symptom, or 5% in small cell cancer, you know, survive, like, things like that. Actually, if there are statements true or false, this is statement and these are difficult to answer sometimes. Statement type of question actually that really test your depth of knowledge. Okay, like you are getting a lot of information from our classes, what is necessary for the exam, but some cases they will also test your depth of knowledge. So that time, those of you who have a depth knowledge in medicine may answer those questions actually. Okay, now there's another thing, data analysis on analytical questions actually, which is more like a biostat. Okay, biostat, you see, at the end of the classes there is a biostat related video. We'll send you link on that one, the biostat relevant video. Also, we already seen that or discussed today asthma, which one is a risky drug. AC inhibitor we discussed. So every diseases there would be risk related one two things. Risk related one two things would be there. Okay, very important. And they might ask you some kind of specific symptom, like which one of the following is the most specific symptom of this particular disease. So example, in cases of stomach cancer, they might ask you this. In case of esophageal cancer, in the next class you'll see they'll ask you, they'll give you 5 symptoms. They'll ask you which one is most predominant symptom, and you have to pick up one in that case. Also, there would be things like a association, like a ZRD and the asthma, how these things are association. So those others were missing, and I'll also tell you with an example in coming days. Don't worry. When the admission would be closed and things, and individually I'll give you example actually, how things looks like. Now let's come back to the things. So type is another one of the thing, right? Guys, I was mentioning type is another one of the thing, another way they can test you the topic actually. So most commonest, this type of question is common in MC exam. So most common, what do you think? The most common lung cancer is a squamous cell carcinoma. Which one is most dangerous lung cancer? Now is another cross question is coming. Even that dangerous, at the time you are sitting with the result, because when you do the test, the result came after some time. So at the time you're sitting with the result can change. It is that dangerous. So this condition is, we call it, this condition particularly, we call it what? We call it, small cell carcinoma. We call it small cell carcinoma of the lung. Okay. One of my relative, he had actually developed adenocarcinoma. Actually, it was asymptomatic at the time. There was a coin-shaped lesion, and then we figured out later that there were symptoms there. I mean, at the time, there was a lesion we did see, and when later he diagnosed with adenocarcinoma. He was a non-smoker. So here's the question: can non-smoker can develop lung cancer? Quick question: can a non-smoker also develop lung cancer? It's always not as has anything to do with smoking. Most of the cancers are first of all genetic, then comes environmental. Okay, so adenocarcinoma is not linked to smoking in most cases, but the squamous is very much related to smoking. So those of you who are still with the cigarettes, please change it. Now, I'd like to ask you a controversial thing. A lot of people are changing into vape. Smoking nowadays are changing into vape. Now, is vape is also safe? Quick question. So thing is maybe less addictive was the one word because it's more like flavory thing. But again, anytime you are exposing yourself to chemicals, remember one thing. Anything you are exposing to chemicals is always been a harmful thing, and you are doing it every day. So no matter what, uh, it is dangerous also. Okay, it's just like a mental satisfaction. Okay, maybe nicotine is, you will get more habituated, like probably vape is little less addictive, I would say actually, but the dangerous level, no one knows actually. Okay, a lot of researches are going on that one. Okay, so this is another thing. So squamous cell carcinoma, next my important thing is to discuss is a paraneoplastic syndrome. So there will be lung cancer and Cushing syndrome features actually. Patient has a moon face, buffalo humps, stria, okay, blood pressure high, along with a lung cancer feature. Now, which lung cancer I am talking about here? Lung cancer with a Cushing feature. So we are talking about a small cell carcinoma of the lung because ACTH and ADH. Now, two things here. In that case, like ACTH and the ADH. Okay, so one of the lung cancer which has a ACTH plus lung cancer related to Cushing. So small cell carcinoma of the lung. It can be also related to increased ADH, which leads to SI ADH feature. Again, it is related to small cell carcinoma of the lung. Okay, these all are related to, these are the paraneoplastic features. Paraneoplastic features. SI ADH I'll teach you in the endocrinology. So what happens with the urine and this, that we'll talk about that one actually. In SI ADH, there will be concentrated urine mainly. We'll talk about that in future. Okay, so Xander, now, do you know any particular paraneoplastic feature of small cell carcinoma of the lung, squamous cell, sorry, squamous cell carcinoma. Do you know any paraneoplastic feature? Now that's a key thing. And that one is a PTH. PTH stands for, parathyroid hormone. So parathyroid hormone is related to regulation of calcium. So if you find parathyroid hormone increase hypercalcemic features, along with the hypercalcemic features, how do we know there's a hypercalcemic features? Did you know this mnemonic? Stones, bones, gones, bones. It's MBBS thing, isn't it? Have you heard about this one? As well, just write it as a yes, no. Stones, bones, cones, bones. Actually, stone means renal stone. Bones mean, the bony, bone loss. Bones means this, abdominal bones, like constipation. Bones means psychiatric bones. They're like psychiatric changes, actually. So all this can happen with a hypercalcemia or parathyroid up. These all are features of squamous cell. So squamous can have association with this PTH. You see this PTH. All the squamous in the body can also have a common criteria. You see these pearls. These are the pearls. So keratin pulse. Every, not only in lung squamous cell, every squamous cell carcinoma, if you do the biopsy, you'll find this pulse actually. All right. It's an interesting thing. And the adeno for non-smokers and the large cell. So mainly squamous, adeno, and small cell carcinoma tested in the exam. Now, how do we test? How do we test? Normally, what do we start with? Investigation. What is the investigation we like to start with? Anyone? We start with an X-ray. In X-ray showing a coin-shaped lesion or a shadow or any abnormality. What is next after that? So after next is a CT scan. After next, okay, is a CT scan. But how do we confirm? Is it by CT scan? Not always. We confirm by biopsy. By CT scan, can we differentiate type? Understand the basic. By a CT scan, can we differentiate the type of the lung cancer? The answer is a CT scan cannot differentiate the types. Most cases cannot differentiate them. So we need the biopsy for that actually to rule out the type of the lung cancer. But biopsy is a very difficult procedure and it's very, very painful. As I mentioned, one of my relative had that adenocarcinoma. He was saying rather I died because of rather doing this test. It was that painful actually. Yeah, because you imagine your pleura and this thing. Yeah. So X-ray, then CT scan, and then coming is the biopsy. Now, is it always biopsy or is it a bronchoscopy? Let's see your basic. Now, you see here, bronchoscopy, if for the central areas, if it's related to bronchus, then bronchoscopy, like the machine came up and then get it actually bronchoscopy. If it's in the peripheral side, that is the biopsy, and that's become even more painful. Okay, that's the thing. So the basic is the peripheral side is the biopsy, and centrally it is the bronchoscopy. This is a basic, but a lot of differentiation things can be there actually. Okay, disease wise things can be different. We don't need that specific information actually at this level. And this is a mnemonic for the paraneoplastic features. Short mnemonic is fair. Now we'll also have another type of lung cancer. Did you know in the apex of the lung there can be a tumor and it can show Horner syndrome? It can show superior vena cava obstruction. Okay, and we're talking about Pancoast tumor. We're talking about what? Pancoast tumor. Actually, it can show Horner syndrome. It can also show, yeah, superior vena cava actually. So again, later you need a CT scan. There was a question in exam. How you diagnose that superior vena cava obstruction? Often an underlying cause is a Pancoast tumor. So you need a CT scan to rule out Pancoast tumor. Clear, everyone? So superior vena cava obstruction or Pancoast tumor, you need a CT scan eventually. All good? Great. So summary here, as you can see, ACTH can lead to Cushing, SIDH. Yeah, so small cell carcinoma can have these particular features. Let's zoom it a little bit. Cushing related, this information I think we have seen in MBBS. I'll teach you in endocrine. These are the some Cushing features. SIDH, this is our endocrine note. I mean, it has a 6-7 slide down. SIDH. Excess ADH will leads to what? Yeah. So anyways, Okay. So talking about this last segment, are we clear about the types, dear doctors? So X-ray, then CT scan, then the bronchoscopy or the biopsy. Up to this, is it clear? Please confirm in the comment section. We can jump into the next segment then, actually related to lung cancer. Next one. Now, asbestos exposure can give rise to lung cancer and mesothelioma. Is this statement is true or false? Asbestos exposure. Now, where asbestos is found, did you know that, in old days, your household painting and all this thing, there was asbestos was used in roof, old houses, asbestos was used actually. Okay, especially roofing. Yes, old buildings. Okay, even in UK, there's the houses are old actually. Some houses still exist, but there's a lot of law they have brought that uh, houses before this particular year, everything has to change actually. Then it was gone, but previously there was a lot. Okay, yeah, the old towns actually, yes. So asbestos related, this is the thing. Now, asbestos exposure, long exposure, it's not a short exposure, long asbestos exposure can leads to lung cancer and mesothelioma. Now, AMC asks weird questions sometimes. They ask one thing, asbestos causing lung cancer more or asbestos causing mesothelioma more? Now, in that case, I'll give you a tip. If you have confusion, you should try to choose the one that is more common. And also, reference-wise, lung cancer is much more common, actually. Okay. Some cases, if you are stuck in this kind of situation, the one that is more common is probably your answer. This is a tip. Okay, so the answer was lung cancer because most cases there's a Davidson nice picture on mesothelioma, right? That a mesothelioma, asbestos exposure. So everyone have this thing in mind. Oh, asbestos exposure means always mesothelioma, but asbestos exposure means also lung cancer, and it is even more common because lung cancer is more common than because mesothelioma. The first line mentioned it is a rare condition. Okay, which is more common in plumber, roofing, mining industry. Okay, and mesothelioma also have ground glass appearance. Actually, if someone is having mesothelioma, they will have some sort of a thickening and some sort of ground glass appearances. Actually, especially any occupational lung disease, there would be ground glass appearance. Clear, everyone? Any occupational lung diseases, you are expecting ground glass appearance. Other than in mesothelioma, you will also find pleural thickening, which is visible on the CT scan. CT scan is important in AMC. A lot of CT scans you will find. Okay, so that's the thing. Yeah, okay. All right, you will find me in social media and these things. You can follow. Sometime I also post some stories regarding the, something note and things. So you can find me in this one actually. YouTube one is the more prominent, especially sharing AMC basic informations. And Facebook you can follow actually sometimes actually. Insta, I mean, for messaging, you can use the Facebook would be better. Yeah. All right. And YouTube, you can see any videos. You can also comment in the YouTube section. You can find things like that. Okay. Are we clear about bit lung cancer related thing? Now let's see what John Mustak has to say. What is the age group? We are expecting over 50. Cigarette smoking would be common. Um, Death more in probably men in some cases, or is it in female most cases? What do you think? Lung cancer is more common in male or in female? New study shows it's more increasing in female. Correct me if I'm wrong. More in smokers, that's the basic. The new study shows probably the smoking in female is also increasing. That's another thing. Now, in our country, we thought that, girls don't smoke much actually. If you come here, you'll see girls are smoking even more actually. Okay, so lung cancer, these are symptoms we discussed already: cough, chest pain, wheeze, hemoptysis, weight loss, unexplained weight loss. You need chest scan CT and you need a biopsy and this, that. And here's some clinical features actually, as you all can see. Already discussed some of them. You can just have a look. Um, and last but not the least, yes. Okay. So does it look in complete this bronchogenic carcinoma or the note is looking better? What do you think, guys? Someone asks how we study after your lecture. You will study with your eyes after my lecture. Sarcastic joke. Okay. Now you will follow the John Murtagh. You will follow also notes. Yeah. So initially, first 2 weeks, you may have little problem, but you will get through it actually. Okay. But I would recommend you to follow both actually. Yeah. So I think you see some informations are also not there actually. Okay, so in that case, just take help from the note, just to be sure that you are not missing anything from the John Murtagh. Because see, now I'm taking the lecture, you remember everything. Later, you may forget a lot of things. Say, imagine after 5 months, right? Imagine what happens after 5 months. You might miss a lot of information, while revising. So that time, the note might remind, oh, doctor also mentioned this thing in the class. Okay, clear now? All good. All right. Next coming is a thing that is the mesothelioma. So mesothelioma mostly again it's a plural cancer, isn't it? Mesothelioma is nothing but a plural cancer. We are at page number 397. We're at page number 397. I'm just taking away the screen just for a second. Please mention in the comment section. What is the investigation you want to do for the mesothelioma? What is the investigation you want to rule out for the mesothelioma? Okay, initial question, very popular question in the exam. Doctor, I'll do make an inquiry zone after the class. Okay, so you guys can ask those questions in the inquiry zone. Okay, how about that? Actually, I mean, probably so many people are asking me things, because I have to conducting class actually. So I think I'll keep a inquiry zone, and you can ask anything. I'll just keep answering one by one. Okay, now here is the thing, talking about how to initially we always start with X-ray, and in X-ray we might see pleural effusion. Quick question, is pleural effusion is a disease? Now guys, we are not going to teach you pleural effusion, actually it's because MBBS thing. Try to read the pleural effusion exudative causes and transudative causes. Is pleural effusion is a disease? Not really. It's a sign that it can be exudative cause or transudative cause. Okay, so exudative can be the infection things. Transudative can be the protein loss things like CCF, cirrhosis, nephrotic, those things, right? So even in mesothelioma, there can be pleural effusion. So it can be a sign that there can be underlying mesothelioma as well. Okay, so initially that's why X-ray is important. So you can see the pleural thickening in the CT scan later. Yeah, later we can do the, yes, later we can do the CT scan actually. Right. So this is very, very important. Mostly they will give you the CT scan things. And also they will tell you about the asbestos exposure. Someone is a plumber, someone is a working with the roof or shipyard, occupation. So mesothelioma. All right. Another CT scan they will give you like this, mesothelioma and normal CT. Please check this one out. This is a normal CT scan. The normal CT scan. Can you see some changes? Can you see the differences, the cavity of the lung? I think it's very much visible. It's almost gone. Too much pleural thickening. So that's the mesothelioma. So this CT scan is often very popular in the exam. Clear? Initial is an X-ray. Initial is an X-ray, my dear doctors. Clear now? So initial is an X-ray, then comes the CT scan. It's a malignant tumor. It's mentioned, my dear. Mesothelioma is a rare, I mean, use that word, rare malignant tumor of the pleura associated with asbestos exposure. Okay. It's getting less day by day because asbestos is no longer exists that much. Okay. Unless it is related to occupation or factory workers or plumbers. Yeah, the occupation. So it will be associated with chest pain, dyspnea, weight loss because it's a cancer, and pleural effusion. That's based on that thing. And eventually you need the biopsy. For further confirmation, you need the biopsy. So again, same thing like lung cancer, X-ray, CT scan, and the biopsy. The histology will always find out by the biopsy. Quick last question. Is the prognosis is good? As like squamous cell carcinoma of the lung, very bad prognosis. Mesothelioma also has a very bad prognosis. Clear, everyone? We are done with the cancers. We are, I think, done with the cancer-related things actually. Shall we move into the restrictive lung disease? Do you remember what are the criteria of restrictive lung disease now? Now you guys need to tell me. Restrictive lung disease criteria. Tell me some criteria. So decrease residual values, decrease total lung capacity. It's more like a diseased lung, important lung, does not really have capacity. Okay, another thing, FEV1. What information do we have? FEV1 by FVC. Did I mention something? Yes, it is 75% or more than 75%. 75% or more than 75%. So FEV1 by FVC will be normal or increased. Well done, guys. So this is the information. And what are the examples? ABC is related to obstructive. All other or the rest are restrictive lung diseases, like starting with sarcoidosis, lung fibrosis, occupational lung disease, interstitial lung disease, all those chronic conditions. Under occupational lung disease, there are many more, right? So all these things are the, yeah. Okay. Can you do a quick recap? No, I think it would be too much time consuming. We'll be posting recording. You can see it later. Actually, it would be too much time consuming to go again with a obstructive lung disease recap. Maybe you joined later, looks like. All right, my dear. Okay. Recap, perhaps we can do the next day when the recall class start. We can do a quick recap on those obstructives. Yeah, that'll be good. Recap should come actually, the immediate next day, right? You see that TV series as, when the class is already ongoing, yeah, it's already supposed to be in your mind, right? Unless you are a Gajni, short-time memory loss, that's a different thing. Yes. All right. So make sure, no one is having short-time memory loss. And even if you have short-time memory loss problem, try to keep it as a long time actually. Now, let's focus on the sarcoidosis. Let's focus on the sarcoidosis. We do have a note, right? We do have a note already. We have seen on sarcoidosis. I'm just taking you to the note, walking you to the note. Okay, sharing now, screen. So let's go through the note and then we'll come back to John Mortag actually. Okay, so restrictive lung disease, I just mentioned about some of the criterias of restrictive lung diseases, right? So here are the points of restrictive lung: total lung capacity, residual volume. These things are, yeah. Now, is it important to do an X-ray is in case of sarcoidosis? Guys, it's a first class, so I'm going little in a slow pace. So usually class durations are 3 hours actually. Still 3 hours not completed. So I think we are fine. Class durations are usually 3 hours actually. I think we expected to finish by 3 hour, 10 minute. Okay, you can understand, we had a orientation in the beginning, so taking a little time. It's a good thing, like someone is taking a class, yeah, giving you more time. Yeah. All right. Unless it's too boring, you can also mention, I can stop it immediately. All right. All right. Now coming to this particular part that, in case of sarcoidosis, is doing an X-ray is very important. It is very important. And what is that X-ray finding? Bilateral hilar lymphadenopathy. Both side. Bilateral hilar lymphadenopathy. This is the main thing. Already mentioned. So another Ghazni we found is 463. Previously mentioned, right? The page numbers, but it's okay. No problem. All right. Now, in case of sarcoidosis, first information we have is it's a restrictive lung disease. So most cases, is it reversible? I'll start with that question. Is it reversible? The sarcoidosis things. Answer is a no. Most of the restrictive condition are not reversible. It's like a irreversible changes. Uh, is it true sarcoidosis has a multi-system involvement? Another quick counter question. I'm telling in that way so that it implicate in the brain. You must be thinking I could have just quickly tell, but it doesn't implicate in the brain. It's a multi-system involvement, including lungs, including skin, including eyes, liver, skin. Many things get involved. So what is important for AMC to remember? For AMC to remember, you have the lung symptom. Secondly, you have to remember there's a unique feature, bilateral hilar lymphadenopathy. Must remember this. Third thing, important thing to remember, it gives rise to a skin condition. And here is a picture of that leg, erythema nodosum. It will be given in the exam very often. So erythema nodosum. Clear, everyone? Very popular. But there are eye features, there can be liver features and other features also there. You can check it from the John Mort tag. Yeah, lupus pernio, and I can also have uveitis and this, that. But these three are most important: lung feature, bilateral hilar lymphadenopathy, and that erythema nodosum. Clear? Now, coming to the investigation, what investigation, like same type of investigation. Have you noticed, like, so far what we are doing, this is a common chain of investigation: X-ray, CT scan, biopsy. Have you seen in last few diseases, it has been very common? X-ray, CT scan, and the biopsy. That's been very common. Now, CXR, ACE level raised, calcium level raised. Now, these are some additional, we can see, information actually. Okay, so in only case of sarcoidosis, other than those three tests, X-ray, CT, biopsy, for additional support, what you can check is the ACE level in the lung and the calcium level. Clear, everyone? This is mentioned in one of the textbook actually. And it also tested in one time in the exam, especially this ACE level is tested. It was asked actually. Other than X-ray, what you like to do initially, would like to do an ACE test. Now, other tests available, urine, these things, we don't need that one actually at this point, okay? Next is a physical examination, what you are expecting. Of course, it's a restrictive lung disease, so mostly unremarkable in the finding. Initially, are you expecting any finding? Tell me one thing. Initially, are you expecting any finding in sarcoidosis? The answer is probably not. Maybe only weakness they will be complaining. And at some point when it will be starting little prominent, there will be inspiratory crackle. Most of the restrictive lung disease, remember one thing, they may have inspiratory crackles. Most of the restrictive lung diseases, this is one of the feature, inspiratory crackle. And spirometry, if you do FEV1 APC, that's a different thing. Clear, everyone? So this is few information about the sarcoid disease. Now let's go to the John Murtha. They started, it's a multi-system disorder, already mentioned, lung issue, hilar lymph node, an X-ray showing hilar lymphadenopathy. Okay, and initially I mentioned they might feel weakness, this, that. So most cases it will remain asymptomatic. Okay, even in young age it can happen, like a 30, 40 years. So here is the thing: lung cancers will be given after 50, whereas sarcoidosis cases would be given 30 to 40 years. Another important information. Other informations are given here also. I marked the erythema nodosum because picture has been tested in the exam. You can only mark that part. Some people has a habit of marking everything in the book. Actually, it looks nice, but understand one thing, not always it is that effective actually. Or unless you are marking everything with yellow, major other points you mark with a green or red. Okay, depends. Okay, so here is the same thing again, X-ray, uh, CT, and biopsy. Biopsy to further confirmation. Biopsy for further confirmation. Here is the thing: initial X-ray, next CT, further confirmation, biopsy. I hope so it is clear. All right. Yeah, we'll post the recording. I think same question again and again. All right. I think planning to leave the class. If there is trouble with recording, I don't know. Sometimes. All right. Here's the thing. So that's the thing about the sarcoidosis, and you need to give, other than the respiratory support, you need to give corticosteroid, right? It's a multi-system involvement. Some cases it is also autoimmune, so you need to give a steroid. Clear, everyone? So sarcoidosis, the treatment includes steroid. Hypertensive pneumonitis, these are chronic diseases, and also uh, you can give steroid actually. Okay, it's less tested in the exam. All right. Now coming something. Chart on occupational lung disease, because we're discussing the restrictive. In short, what it is called, all the occupational lung diseases, it is called pneumoconiosis. Pneumoconiosis. Everyone knows this information. It's technically called pneumoconiosis of an or occupational lung diseases. It has a lot of types. You can see asbestosis, berylliosis, coel workers lung, and the silicosis. For AMC, most popular, let me tell you two of them so far tested in the last 10 years. One is a silicosis, this one, and one is asbestosis. Asbestosis I already mentioned, and if you see a line here, risk of bronchogenic carcinoma is more than mesothelioma. Did I mention this line? Yeah, so it's a very important line. And this can lead to lung cancer or pleural thickening. Pleural thickening will lead to mesothelioma in that case. This asbestosis often presents as a pleural effusion. So either as a lung cancer or either as a mesothelioma, but initial presentation would be pleural effusion. Can remain asymptomatic, and when present, when symptomatic, pleural effusion actually. Clear, everyone? One basic thing about all the occupational lung disease, if you do an X-ray, what will be your finding? A quick thing to recap again, just to remind, I think I mentioned that one. All the occupational lung diseases, if you do an X-ray, what you will get? Ground glass appearance. If you do an X-ray, you'll find a well done, doctor. I think one doctor mentioned it's a ground glass appearance. Well done. Yeah, so all should remember that actually. Okay, then few things about berylliosis. Nice to coal miners. Yeah, you can also remember working in coal can lead to fibrosis, coal miners. So asbestos is directly important. And another one is a silicosis. It affects mostly the upper lobe, eggshell calcification in the X-ray, eggshell calcification. And another key word, there is a history of tuberculosis or susceptibility to tuberculosis. Okay, this is to remember, extra line, susceptibility to tuberculosis. Okay, so please remember them, can be useful. All good. That's the um, occupational lung diseases. Let's see another slide. Yeah, maybe you can take a picture of this one. This one can be useful some cases. Yeah, sometimes some keywords, like especially this one with the immigrations, the tuberculosis. This is one of the important for the immigrants, uh, the tuberculosis. For going to Australia, like many of you been to already Australia, what is the one test we all had to do? What is that one test we all had to do? The TB test, right? This is the main test we had to do actually, TB test. Yes, great. Most cases we had to go through the X-ray, IGRA, if I think they suspect something and then ask you for IGRA, I guess. Yeah, we had to go through the chest X-ray and rule out the TB. Yeah. So here are the things. Please remember these particulars, the additional. Okay, moving back to John Motta. Don't worry, we're almost at the end. I won't take much of your time. And there is a one thing about the tuberculosis. The page number is 184. Sorry about things are in different pages. The typical tuberculosis is not tested in MC. Okay, the typical tuberculosis, the pulmonary tuberculosis is less commonly tested because quick question, is tuberculosis present in Australia? Exist in Australia? Quick question. Is a condition like tuberculosis present in Australia? Answer is a no. Some cases possible if the immigrants are coming. I mean, Some immigrants may have it only actually. The typical OZ, they have tuberculosis, very less likely. I mean, it's almost mostly if immigrant, that's why there's so many cross-checking. But even with the X-ray, we know TB can be limit dormant. So some other can have. The BCG vaccine we take is in Australia, they give BCG vaccine. Another quick question to all of you. In the typical BCG vaccine we have taken in Australia, does they give any sort of vaccine for TB? So the answer is a no. They don't give any vaccine like for the TB. Now coming to the pulmonary tuberculosis, yeah, yeah. I mean, if it's necessary, then it's a different thing. You'll not find any spot in their hands or in the legs areas. Okay. Now coming about the tuberculosis thing, let me just shortly tell about the TB. I'm just highlighting the pulmonary TB. Most of you know. I'm not going to explain that thing actually. All right. What pulmonary tuberculosis? What are the symptoms, guys? You all have dealt with TB. You are even more expert than me in TB. So tell me about tuberculosis. It's a common disease, very common disease in our, Asian and many of the subcontinents. Affect the lung, affect the multi-system. So it's a multi-system disease. So multi-system disease. So starting with what? Starting with, yeah, cough. Like if cough for more than 2-3 weeks, we start counting. Then, there'll be low grade fever, low grade fever. Can there be weight loss? Yes, there can be weight loss. At some point, there can be hemoptysis and there can be hemoptysis too. Okay, so these are some of the initial features. Many other things it can be. Depends on where is the TB, but we are currently talking about the pulmonary TB. Okay, that's the thing. Now, if these things are there, you need to go with some test. What test you want to do? Quickly, guys. I mean, we don't have much time. So we'll start with an X-ray, doing an X-ray. An X-ray will show some sort of patchy opacity or diffuse lesion in some cases. If miliary TB, that's a different. But is it confirmatory? No. I mean, how can we confirm? We can confirm by sputum culture. This is very, very mandatory. There's a very important line to remember. If the patient is symptomatic, you definitely need a sputum culture. This is an exam question. If it's a symptomatic patient, you definitely need a sputum culture actually. Then there are tests like IG, RA, many other things. I mean, pleural effusion analysis, aspiration of pleural effusion, if there is a pleural effusion present, and those things will come up. Then there is like a tuberculin test. Tuberculosis. Often, X-ray and the uh, tuberculin test or Montauk's test. Yeah, similar words almost. Yeah, so tuberculin test, Montauk's test is done almost initially. These two. Okay, so these are the things. Okay, then if you are diagnosed positive for TB, and what are the treatments in that case? So there is a 2-month regimen, and there is a another 4-month regimen, right? So in the 2-month regimen, there is a 4 drugs given. You all must be knowing. And for the remaining, the continuation phase, another 2 drug given. That 2 drug is the isoniazid and the, yeah, isoniazid and the rifampicin. So remember one thing, check out the side effects. I'm not going there because it's almost at the end. I think it's MBBS level thing everyone can understand. Most of the antitubercular drug are enzyme inducer. They also can affect the liver. Many has symptom like peripheral neuropathy. I'm going superficial with this thing because I believe you guys know this thing. Isoniazid can cause peripheral neuropathy. Then rifampicin can cause orange urine. Then hepatitis, all of them can cause. In ethambutol can E for eye. Remember as the eye problem. Okay, and another one is what? Pyrazinamide. Pyrazinamide can gives rise to hyperuricemia, right? So these are a lot of individual things you can remember actually. Yeah, you can remember. Okay, yeah, this in individual more other side effects. I'm just telling in general right now actually. Okay, now all this thing I said, will it be tested in MC? No. Okay, That's a good joke. So what will be tested? I'm going to show you now. Okay, that was a good joke, right? Whatever I just said about the TB will not be tested. Okay. Now, what can be tested is now here actually. It is what? It is a latent tuberculosis. Now, have you ever saw your professors giving anti-tubercular drug, even TB was not positive? Have you seen any case like, oh, I think this is suspected TB, let's start in drug like isoniazid, artemether, or anything like that. Okay, as a trial, maybe underlying TB. Many you have seen actually that in the rounds, right? Empirically. So this is suspecting latent TB, like symptoms are not there, but is still suspecting the symptom, in that case, latent TB, and also previously probably not vaccinated and informations are not there. So in that case, liaise with expert about the appropriate treatment. Means you can start the isoniazid. Isoniazid you can start in that latent tuberculosis case. Okay, so this picture you might be needed. Actually, it's just this picture is taken from the RSCGP. RSCGP, or you can search latent tuberculosis RSCGP, you will find this chart actually. Now, the recall question next you will saw, it was mentioned the patient does not have any other symptom except for the sputum for 3 weeks. Now, tell me, is this patient is symptomatic or asymptomatic? The patient has nothing else, but the patient is having sputum, sorry, the patient is having cough for 3 weeks. So should I put it under latent or should I put it under symptomatic? Okay, a lot of people make this one as a mistake. So I'll put it as a symptomatic. So an X-ray already done and showing inconclusive. So the question was, should I consider it as a latent or should I do the sputum? The answer is there. I should go and do the sputum because this 3 weeks considered as a symptomatic. Clear now, everyone? Yes. So this is another uh, confusing question from the latent TB actually. And if it is confirmed and this, that, then you can go with a normal TB treatment. If it is, you don't know, you are not sure this, that you can go with the latent TB treatment. All good. This is the picture for latent TB. I'm holding here for 2 more seconds. If you want, you can take a screenshot of this one. The latent tuberculosis. All good. This brings us to our last segment of today. We talked about all these things, and last segment is talking about um, the infection of the lung. What is infection of the lung is called? Lungitis. What do you think? Okay. Okay. Even though this one is our one of the feature of emergency medicine, but it is everywhere. The pneumothorax. Okay. Before pneumonia, let's just take 2 minutes for pneumothorax because it will be again discussed with the emergency medicine. These are the topic that is tested from pneumothorax in the main exam. So you'll be needing the types, clinical feature, investigation, management, differentials, because someone coming with asthma, you are still doing X-ray. Why? To rule out pneumothorax. Why it is so important to rule out pneumothorax, air in the pleural cavity? This can take your life in minutes, isn't it? Even more dangerous than a snake bite. Am I right, guys? A pneumothorax can even more dangerous than a snake bite because a snake, you have the chance that it can be a non-poisonous snake. But if you have a tension pneumothorax, without releasing the pressure, any chances of survival? No chances. Okay. So tension pneumothorax will not give you any chance. There are other two types of pneumothorax, open and closed pneumothorax. In that case, you have time. So in that case, you don't have to insert the needle in the second intercostal space immediately. Rather, you can give, water seal drainage. We call it chest drain, right? We call it chest drain. In AMC, that word comes as a chest drain actually. Okay, so if tension pneumothorax, uh, mediastinal shifting like apex beak shifted, then trachea shifted, you don't have time, my dear, you quickly go for a releasing the pressure. My professor used to say they used to even insert the pain holder in the village areas. if the suspect pneumothorax was that dangerous. So here is the thing, needle thoracostomy. This is the line they will give you in the MC exam, needle thoracostomy. Okay. Now what MC has thing to mention, they'll give you a picture like this of a pneumothorax. And there's a 25% rule actually. Lung collapse percentage, they call it actually. If less than 25%, no symptom, you just observe. Okay. Not talking about the tension pneumothorax, talking about the general pneumothoraxes. Tension pneumothorax, quickly insert the needle, release the pressure. Other pneumothoraxes, this is the management. So it depends on the lung collapse part actually. Less than 20%, no symptom, observe. Less than 25%, symptom present, drain. Remember one thing, anytime symptom present, you need to drain it. If more than 25% or equals to 25%, also chest drain. Is it clear, everyone? So symptom present is always drain. And if it reaches anyhow 25% or more than 25%, again, chest drain. Okay, and tension pneumothorax, insert that needle actually. This is the main area where a lot of question comes actually from the pneumothorax. Okay, now in a slide, why my notes are important to read, I just highlighted what are the things actually tested from the pneumothorax so far in the last previous years. Okay, so major things, how to make a quick diagnosis of pneumothorax. In the exam, you will find a line, reduced air entry. Is it a common thing for a pneumothorax? Reduce air entry in the affected side. And when you do the percussion, it will be dull. Now, normally, that's more than enough. Reduced air entry in the affected side. But is it giving me a clear picture? Is it a pneumothorax or is it a hemothorax? Because both cases reduce air entry in the affected side. Now, the game begins with the percussion. If percussion note is hyperresonant because it is air, it is pneumothorax. Percussion note dull, hemothorax. Clear now, everyone? So this is another important question, often given as a pneumothorax, often given as a hemothorax. Third important one is a tension pneumothorax. X-ray can be given, trachea shifted, apex beak shifted, mediastinal shifting. We don't have time, needle thoracostomy. I have already mentioned that. Regular pneumothorax, chest drain, but depends on 25% rule. 25% rule is what? Already I have mentioned this one. Clear? Okay. Next is a radiology. So they might give you radiology and you will see trachea and this thing shifted. Sorry, it was not clear. You can Google it for any pictures actually. So you can see the trachea and these particular things are shifted. Okay, this is another thing. There's another special suggestion or suggestive type of question also comes. Which of the following is true about, or what do you give the best suggestion for a pneumothorax patient? Answer is a do not air travel for 3 months or do not go for driving. He will not go for driving, I mean, under the water, but he can travel, right? If he does not know. So avoid air traveling for next 3 months. Very important for the exam. And already you know about the rule of 25%. So these are the maximum way pneumothorax can come, and also sometimes can be given as a diagnostic question too, as a diagnostic question too. Okay, is this thing helpful? Please let me know in the comment section. I mean, your feedback is important or motivates me making more crunchy notes like that actually, like these are the best possible way thing has been tested in the exam so far. Okay, next, going for the next. Okay, so we are done with the pneumothorax. Pneumothorax, let me tell you, it will come again with our emergency medicine. Okay, it will again come with our emergency medicine actually. So the last topic of today, it is the pneumonia, which is the inflammation of the lung tissue. Inflammation of the lung tissue. We are at page number 393. In 5 minutes, I'll be finishing everything, so don't worry. Avoid air travel means actually aeroplane, because your lung will be under a lot of pressure. Okay, clear? Yes. Yeah. Pulmonary embolism is a surgical topic, surgery topic, surgery and also emergency topic actually. Good question. Okay, my dear. Yeah, we can put also into respiratory, also put also into surgery, but we'll be definitely discussing in the general surgery. We have a separate slide on that one. Okay. Or maybe in the recall class, if I get time, I'll draw something for you about not today. I mean, if I tell about pulmonary embolism now, half of you will start developing DVD now for sure, but sitting for a long time, right? Sometimes stretch your legs, guys. My classes might give rise to pulmonary embolism. I don't know. Okay, fun apart. Let's not. Let's finish it, guys. Actually, pneumonia. Tell me three about the pneumonia. Pneumonia is a infection of the lung. So let's again start with the symptoms as like before. So your lung is in trouble, lung is inflamed. Most cases, one lung is affected, right? One particular area. In AMC, mostly they will ask you, give you an X-ray, X-ray showing middle lobe consolidation. This is a very popular in the exam. Middle lobe consolidation. And they'll ask you what to do next on this, that actually. Now, what are the symptoms of pneumonia? Quickly, if I ask you. All right. Yes, well done. If you say because it is infection, you are expecting a fever, and this fever would be very high fever. I'm marking it separately as a high fever. I'm marking it separately as a high fever. Okay. The difference with a lung abscess will have an X-ray finding with a air fluid level, and but that one also has a high fever. High fever. You need to give antibiotic and chest drain in case of lung abscess. Okay. We're talking about the pneumonia. So fever, then definitely cough. Yeah, there can be cavity. Yeah, there can be cavitary things, possibility. There is X-ray showing consolidation. These are the things. History is possible, right? There can be history of upper respiratory tract infection. Is it possible? Yes. So there will be a history of infection followed by pneumonia, history of catheterization followed by there was a pneumonia. So there's some entry point can be present, correct? There can be an entry point or immune suppression. Another thing, immune suppression, like a AIDS patient. Are they more prone to pneumonia? Any AIDS patient? Answer is a yes. Someone is taking a steroid. Yeah, more chances. Now, these are the symptoms. Now, if we talk about the types of the pneumonia, there is one you call CAP, community acquired pneumonia, then another is a hospital acquired pneumonia. Okay. Now, hospital acquired pneumonia, what is the time frame? Does anyone know? Like up to this particular time, it is a hospital acquired pneumonia. After that, it is not possibility of hospital acquired pneumonia. Okay. Isn't it uh, kind of like, uh, yeah, I mean, somewhere I read like a 72 hours. Yeah, I think 48 to 70, we can accept that. So someone with a 5 days, I mean, high fever and this, that 5 days, are you expecting pneumonia, hospital acquired pneumonia? In fifth day, someone develops fever and infection thing. Can it be pneumonia or hospital acquired pneumonia? Maybe not. So this information is important for us. So community acquired pneumonia, hospital acquired pneumonia, pneumonia in a immune suppressed people. Okay, then there is a, like another one is a atypical pneumonia. So these all are like a typical pneumonia, typical, and these are atypical pneumonia. These are the symptoms for typical pneumonia. Now, if I draw the symptoms of atypical pneumonia, why they are atypical? Because they only sometimes presented with a dry cough and low-grade fever. This is the exception. Dry cough and low-grade fever. Will the X-ray will be also less prominent? I mean, symptoms are less prominent, but X-ray finding is very prominent. X-ray predominant. X-ray is a prominent finding. So can we write a line like that? Less clinical feature, more radiological. This is applicable for atypical pneumonia. What is the treatment for atypical pneumonia? What do you think? Yeah. So mainly you will go for a azithromycin. Doxycycline also in the option, but currently new guidelines says like they are more up to using the azithromycin for atypical. Now, what are the causes of atypical pneumonia? What can be some of the causes? Can you mention one or two? Did you know the name of the mycoplasma? I'm sure you heard the name. Mycoplasma. We'll follow the John Murtagh. Okay, let me tell you one thing. If there's a confusion between RSCGP and John Murtagh, follow the John Murtagh. Okay, so Mycoplasma, Legionella. So these are the culprits. Okay, what are the big three for typical pneumonia? Can anyone tell? What are the big three for the typical pneumonia? I hope most of you know the name actually. Haemophilus influenzae, then streptopneumonia, then yeah. So you'll find it here. Streptopneumonia, mycoplasma. Yeah. So here are the big three: streptopneumonia, Haemophilus influenzae, and yeah, mycoplasma. So these are some of the big three. Here's some clinical features given: investigation, X-ray, sputum, PCR, these things. Uh, I mean, there are many complications. Many complication. Please remember the emphysema as a complication. It has tested in exam actually. There can be a lot of complication, but please at least remember the emphysema. Please mark that one separately. Clear? Okay. All right. And here some treatment things are given. You can just check it. The treatments of pneumonia, like check in kids cases, check also in adults cases. You have to memorize this particular part. You have to memorize this particular part, including the symptoms you need to remember actually. So last but not the least, today's last topic is have you heard the term carb 65? Ever heard this thing in MBBS? Carb 65 for admitting a pneumonia patient. So according to carb 65, um, yeah. So follow that one. The scoring of carb 65, like confusion, hypoxia, respiratory. This, if all these are present, your patient might be in hospital or in ICU actually. That's the thing. So hospital admission criteria. So just remember that one actually. I don't want to stress too much. These are the guidelines for the severe pneumonia. Yes, these are some of the guidelines for the severe pneumonia. So is carb 65 two or more than two, like a three and this that. And also you see vitals are deteriorating, hypoxemia, same thing, type 1 respiratory failure. Yes. All right. So treatment can be different from mild, moderate, severe pneumonia. Mild cases oral, moderate cases we give something IV or IV, even benzyl penicillin. Severe cases you need a more powerful one, like a ceftriaxone. Okay, guys. So I guess that's the end of our class. Sorry about longer because I trying to go with the general speed. Let me know if my speed was okay for the class. Yeah, gradually I increase, but no, I don't increase much so that everyone understood. I try to repeat things. But I will go accordingly as you most of you want actually, lecture has to be for everyone that uh, understandable actually. Okay, so that's the thing. And we'll get back to you. And if you check our routine one more time, so our next class will be little later because I'll be out of country and admission will be also ongoing in between this period. But you are all open to attend this one, and this whole month there will be admission ongoing. Yeah, so that's the thing actually. Whole May there will be admission ongoing actually. So our next class will be on 23rd. Okay, like after 1 week actually. So we'll be definitely have that one, and you all are invited. So yes, we'll upload the recording. Don't worry, my dear. I'll be uploading the recording. Yes, tomorrow I'll be uploading the recording after taking little fluid. I need fluid. You know, I probably need a spa, I think. I'm just joking, actually, after 3 hour. Yes. Last date, it's the 30th of May, actually. All right. So thank you so much for attending, everyone. I hope it's helpful. And I think our note would be also helpful for many. This is how what note things kind of looks like if before you go. Yeah. So every system has notes, this, that's using medicine a lot. Then comes the pediatrics, this, that. So we made a lot of notes, actually. All right. So good luck. Yeah. And yes, John Murtag's study, only those I mark. Okay. Uh, Mainly in my class, why they're popular and highlighted, those I mark, only read them. Okay. And then extra thing you can find from the forum. If you want to read little extra, you can always go to the Shahriar's MC guideline forum. You can search with the word respiratory. You will find many questions, but we'll guide you in the next class how to solve the question. Yes, yellow mark, green mark, or any mark in my book, you can see. That's the thing, actually. Question bank is also important, actually. Side by side, we'll post a question bank. Don't worry. Question bank will help you to practice. Okay, question bank will help you to practice, actually. That's the thing. If you expect that, okay, so many things will be common from question bank, it's a wrong thing, but it helps you in practice, actually. So we'll provide it, actually. All right. So yeah, we'll be posting the recording. So don't worry. Again, the same question. Recording will be posted tomorrow. You can listen to that one. Okay. So access through the notes. We'll be clearing the notes. Yes. Yeah, question bank, as we mentioned, we'll be posting after. You are not ready for question bank now, actually. Okay. Those of you finished admission, I mean, I will look into who has finished admission and not received notes. I'll be sending, actually, gradually. Okay. Don't worry on that one. You also need to give us some time because we are receiving a large volume of messages. Actually, it's like my inbox, even my team, they're in trouble, actually. All right. Yeah, there'll be mock. I think in the beginning of the class, we mentioned uh, like there was there will be mock after every Sunday, actually. So don't worry. Please check the routine. I think, some people are asking the things, so you can see, just see the routine, my dear. There'll be theory, there'll be recall, there'll be mock, there'll be theory, recall, mock, theory, recall, mock. Clear? Medicine, pediatrics, surgery, emergency, gynae obs, psychiatry, ethics, miscellaneous. All good? No, I don't use Telegram. I don't need it. You guys can open it. It's up to you. Okay. Already wants to hide, So having a Telegram, it would be too difficult, actually. Okay. All right. How are you going to receive notes? You can send your Gmail. If you have already registered with us, you can send your Gmail, or we ask you for Gmail and all this thing. Please understand this process may take 2-3 days to send you the notes and this thing. Already many received, and the remaining will be receiving, actually. It's a process, guys, actually. All right. Recording where to be posted in this group, we'll post it, actually. Don't worry. So please just understand the next class time. Remaining, I'll be open an inquiry zone in our group. If you have any inquiry about today's class or about the course, you can ask there. I'll be get back to you. Okay. See you guys. Yes. Yeah, note will be available as long as you want, actually, till you pass. Don't worry. Don't worry, guys. My recommendation, check the class routine again. Thank you, guys. And better would be if you text tomorrow, because I might be needing little rest today. Okay. So tomorrow, if you text me, it would be good, my dear doctors. Thank you again. All right. Yeah, my back is hurting right now. Actually, please pray for me as well for my good health. And I'm going to a different country tomorrow. So I'll be back in 3-4 days, and it would be, take off from there, actually, a little refreshment before a major course, because we just finished one. I need a little 3-4 days break, and just we'll with you guys. Yes. Leave a message. Our team will be connecting with you. Don't worry, actually.